8 millimeter graft, dacron graft, which we then cannulate as arterial cannulation. Then open sternum, open chest, median sternotomy, and cannulate the right atrium for heavy or venous drainage, and then go ahead to do the surgery. All these patients required root and valve replacement, ascending aorta replacement, and total arch. 2 of the patients needed a frozen elephant trunk, and the 4 others, the rest of the 4 needed only a traditional elephant trunk. So this left subclavian artery would offer both systemic antegrade perfusion, but also offer cerebral perfusion, both antegrade and retrograde. Antegrade through the vertebral arteries and retrograde through the left common carotid. If you look at this image, just the simple anatomy, the left subclavian, just after it comes through the scalene muscles, is quite easily accessible through the supraclavicular area, as compared to if you're to do an axillary artery dissection, which is slightly harder, anyway, according to literature. That picture shows an intraoperative picture of a dissection. I don't know how clear it is to you, but what looks bluish is the area on the anterior aspect of the aorta, is the area that is dissected. So here it's quite hard to cannulate such a patient, because if you're to do central cannulation, because the dissection is just anterior to you, it's hard to cannulate if you're to do central. These are pictures demonstrating the cut down for the left subclavian, and in the first image, and the cut down for the innominate and left common carotid as exposure. So in what you see here is once you expose the left common carotid and cannulated it, you don't have to do a lot of mediastinal dissection to look for the left subclavian artery. And therefore it minimizes manipulations of the arch, because you've already gone on pump. And later on, if you're to deal with the left subclavian as part of the arch replacement, you can directly connect the left subclavian to the left common carotid as part of the anastomosis. Yeah. Here, this I'm just showing you. Here we've exposed, and usually goes around the cannula, and iodine goes to prevent infection, but I don't think it's necessary. So that's how it would appear once you've cannulated and gone on pump. That is the cannula going to the graft that is connected to the left subclavia, and you achieve your antegrade perfusion. So you also have less crowding in the mediastinum, because your cannula is away from the mediastinum. You only have an RI cannula. This is a finished product. The first slide shows one patient who underwent ascending and arch reconstruction. The second slide picture shows the patient. In this patient, they had root dissection, ascending and arch, but also the right coronary artery was dissected, so we replaced and did a bypass graft. You can see venous graft from the innominate artery to connects to the distal RCA. So these patients, following that technique, they did quite well, all the 6 patients. Average bypass time was 3 hours, that's 180 minutes, which is good. Sac arrest, because once you've done this, the only time you need sac arrest is the time when you're doing your distal anastomosis between the graft and the distal arch, and that usually takes about 15 to 20 minutes. All patients were extubated within 3 to 5 hours. They didn't have any neurological deficits, which is very important, and end organ function was okay. They had an average stay of ICU for 2 days, and total hospital stay was 5 to 7 days. And we didn't have any cannulation issues. So what the point of this is to demonstrate that left subclavian artery cannulation is safe, reproducible, and easy and gives you another option to these already established cardiation strategies. The challenge with this case series is that we need a bigger study. We need a more large numbers, most likely to go on and monitor and see how these patients do. So a prospective study would be the best approach. But with this, we think we have demonstrated that this is a safe strategy. Otherwise, thank you for the invite. This is the hospital I'm in, and that's part of my team. Dr. Vikram is there. He's my supervisor here, and he's doing a great job. And I thank the administration for supporting me to be here. Thank you very much.
Thank you, Mr. Habwe, for that very interesting presentation. I hope you can keep online for questions later. Our next presenter, I already introduced him, is Dr. Ariaka Herbert. Dr. Ariaka Herbert is a cardiac surgeon at Uganda Heart Institute, currently doing both pediatric and adult surgery, though he plans to specialize in adult, but we know that he will do a lot of pediatric surgery as well. Now, before Dr. Ariaka starts, allow me to introduce. I said these two have been together, but we have gender balance. There's a third one. She's a lady. And she's Miriam Naule. Miriam, please stand. Miriam Naule is a pediatric cardiac surgeon. Please clap. I'm very proud of her, and she's specifically the future of pediatric cardiac surgery in the country. So you two gentlemen and one lady, there's so much that has been put in you, and we expect a lot from you.
Thank you so much, Mr. Oketjo. So I'd like to acknowledge Mr. Oketjo, who is also my teacher supervisor. This case that I'm presenting actually was a lead surgeon in the operation for this particular case. So we have a 10-year-old female who was symptomatic with a large cardiac aneurysm and secondary application defect. The case report. So aneurysm is basically abnormal dilatation body structures, and in this case you have the right atrium. And next slide. I'm not controlling. Okay. So you can. They say a picture is worth 1,000 words. That picture you can see in the corner there shows you what it's all about. So this aneurysm basically originates from the right atrium and an abnormal dilatation. That means their diameter is more than half the original one of the right atrium. So they are quite rare, and we had a child who came to Heart Institute with easy fatigability and was diagnosed to have a right atrial aneurysm. If they're left untreated, they can be catastrophic because they can cause arrhythmias, and this causes sudden death, and can cause heart failure, and they can rupture. And when they rupture, it's usually fatal, and there can be thromboembolic phenomena that occurs through the ASD. So we present this case, 10-year-old female who came with heart failure, and she had a successful operation to repair the aneurysm, to close the atrial defect, septal defect, and also the interesting thing about this case was that because the heart was so large, we had to first decompress it. So imagine this room being very full, and to enter it safely, you need to create a second outlet. So for this child, we proved that surgery is the best option for managing this kind of condition, because no amount of medicine that you take can cure it. You need to operate on the patient. So notably in the history, when she came, she had an earlier history of chest deformity. She was running around playing. However, this worsened over 1 month prior to admission, when she became increasingly tired. She also had a pectus carinatum with therapeutic marks on the anterior chest wall. The examination, typically, we could just hear muffled heart sounds, but they were there. There are no murmurs, and she had a non-tender hepatomegaly, just about 3 centimeters below the subcostal margin. So we worked up. ECG was a sinus rhythm with a right axis deviation, and boom, on an X-ray, we had a grossly enlarged heart. And after that, we said, what can we do more? We went and did so we did an X-ray. The X-ray really showed that she had a very large heart, what they call a gross cardiomegaly. So the team was further interested, and we went ahead and did for her what they call a transesophageal echo. An echo is an eye into the heart through that you pass through the esophagus. So it showed us that this patient had an extremely large right atrial aneurysm. The pictures will be shown briefly. And all her cardiac chambers, the right atrium, the right ventricle, and also the left atrium and left ventricle have been compressed by that aneurysm. Is this one? Okay. Thank you so much for. So, sorry for the interruption. Yes, so you can see there, we had the transesophageal echo which was done, and you can see right here in the corner, this huge chamber that we have here, which was filled with spontaneous echo contrast. And when you see that, you think, oh, there's something happening there. And you can see right here, we have the heart chambers that are being compressed by that aneurysm. So the blue arrow points to the atrial septal defect, and then the yellow arrow shows you the neck of the aneurysm, and what is outside looks actually much bigger than the heart itself. So we did a cardiac CT scan as well, and you can see that most of the anterior mediastinum has been filled by that aneurysm with this contrast there. So we decided to operate on this patient, and operatively, technology is misbehaving. Artificial intelligence needs to come in, I think, now. Yeah. Yes, so as you can see there, okay, we opened through the sternum, and as soon as we opened it, we found that the heart or the chest was basically filled with a structure, which is not the heart, the natural heart. So this is the right atrial aneurysm. You can see it's the next edge. When you open this aneurysm, we find that it's quite thin, paper thin, and that shows you the risk that it has to rupture. It's quite thin, just like a cavera. So anything that can poke it will be catastrophic. So we opened through the right atrium, and we're able to show you the ASD, which is the atrial septal defect, on the picture in the left. Of course, I'm mentioning all of this in the background that this patient is under what they call a cardiopulmonary bypass, and the heart is arrested in the operating room. So there's a lot which goes on before we get here, which I have not explained. So after removing this paper-thin membrane here, we were able to eventually close the real wall of the right atrium, which you can see here. So after closing this, the patient, we closed the sternum and went to ICU. She had a good recovery post-op. But I'd like for you to compare the X-ray, which was done before the operation and after the operation. The size of the heart, the cardiomegaly, I think she has a normal cardiac ratio at this point, about 40%, which is good. So this patient right now is stable, and she shows no signs or symptoms of heart failure. All sites of operation have sealed well, and right now she's not on any medication for heart failure. So we think that for this patient, she'll have an excellent long-term prognosis. And each time that she comes to the hospital, we screen her once a year to check if there's any recurrence of the aneurysm, and we check if she has any arrhythmias. As of now, she's doing very well. She's in school, and we know that she'll do well. So in summary, we are saying that these aneurysms can be safely operated on using a cardiopulmonary bypass, and we'll have excellent outcomes in them. Thank you very much.
I would like to thank all these speakers seated here, plus Mr. Habwe online, still I believe. Thank you for showing that cardiac surgery is not complicated. And I'm sure the audience has understood what you are talking about. So for that matter, I would like to invite questions from the audience. Yes. Do we have a mic?
Thank you very much. Once again, I'm called Richard Mangui, ESC, and I'm sitting in for the Vice Chancellor of Muni University. Just for clarity, please, whenever we say Muni University, people think about mountains of the moon. It is Muni University in Arua. Okay, so very amazing surgeries you have demonstrated here. The question goes to Kaiser. And it's about the long-term follow-up. You gave us a duration of about 40 days post-op. I would be very happy to understand what happens in the future years of these children. And then secondly, when you talked about survival, you just gave a time period of about 10 years. But could it be possible that your survival also improved with time as your surgeries improved, as your expertise also improved? I would be very happy to know that probably the deaths and other complications could have occurred in the earlier times of 2012, 2013, and so on. And as the years advanced, probably your survival rates also improved. Yes. I'm just assuming. Thank you.
Thank you very much. And at the back. Okay.
Thank you very much. This one goes to Dr. Aliku. Thank you for the presentation. When you were talking about the quality of life and you highlighted the perceived appearance after surgery of these children, were they looking at their scar, or was it, because we know we have these patients coming in cardiac checks here and they're small and all that, was that what they were looking at after? Did they gain weight? Did they, what were they looking at especially? Because it can also help us in counseling them, especially when it comes to the scar. Then for Kenneth, I don't know if you can hear me, but he talked about having, why they were considering the LSA, saying that you have short arrest durations. I don't know, maybe he can enlighten me, but I thought we arrest after we cannulated. So either way, whatever you're using wouldn't be really an issue for arrest duration.
Yes, please.
Thank you, Chair. I'm Claude Shirumuhuzia, representing the Vice Chancellor of Kawari University, and I come from Kawari Medical School. My question goes to Dr. Kaiza. I'm concerned about the large percentage of postoperative infections. And I don't know what you can say. Could it be linked with poor postoperative care or poor measures when it comes to IPC, infection prevention and control? Thank you.
We'll take the last question from the lady.
Cases and the number of surgeries are increasing, and as well the issue of INR monitoring is becoming big. As we think of having probably self-care techniques of where patients can check their INRs, are we also going to plan to have an app that will help them adjust their doses? Because since last week up to now, we've been seeing quite a number of patients, more than 200 who had surgeries in Salam Center. We've been following them up. And one of the challenges I've met is that they do check their INRs outside UHI, and they've been adjusting their doses, and none of them did it so well. They've just been praying about it the way they want. So what are we going to do? Yes, the numbers of patients coming to UHI are becoming big. Testing their INRs is becoming challenging as well. So if we allow them to check their INRs, how are we going to handle adjustment of their doses of warfarin? Thank you.
We'll start with a question for the online presenter. Mr. Harvey, are you still online? So we can.
Yes, sir. Yes.
Did you hear?
Yes, I am.
Did you hear the question?
Yes, I did.
Please, go ahead and answer.
So, thank you, Dr. Miriam, for the question. In this case, the arrest was meant to mean the deep hypothermic total saturated arrest, which is necessary for arch reconstruction. So with the left subclavian approach, when you go on pump, when you cannulate it, go on pump, you cool the patient. We usually cool up to 24. The recommendation is 20 to 24. The lower you go, the higher the risk of complications. Now, because it affords you less time in dissection of the arch, but also reconstruction of the arch. When you cannulate the LSV, the left subclavian, you go on pump, you always arrest the total saturated usually during anastomosis of the graft to the distal arch. During reconstruction of the innominate and the common carotid, you don't have to be on the sac arrest. However, if you cannulate, for example, the innominate artery, to reconstruct the other arch of vessels, you may have to be on sac arrest. What we've tried to avoid here is when you go on LSA cannulation and sac arrest, once you start rewarming, you only perfuse through a perfusion limb of the graft. We think it is an easier option in terms of this, and compared to what my supervisor used to do before. He has found this easier, and it has reduced his mortality in these dissections. I don't know if I've answered your question, Miriam.
Yes, you have, Ken. Thank you. Doctor?
The negative perception was mainly related to the scar. Remember, as Africans, some people will get keloids, so especially when that scar is hypertrophic or has developed keloids, then they will have a negative perception. This was the appearance. Overall, in the study, the mean BMI improved. Actually, the mean BMI was 20.20, which is ideal BMI. So surgery, weight gain, and symptom relief. Summary raises a pertinent question. You know, all of us are in some form of self-monitoring. Weight, I am assuming you know your weight, your height, and your BMI. Many of you have scales at home, isn't it? You are unfortunate and you have pressure, you have machines at home, isn't it? You measure your pressure, you know whether you are controlled or not. Some of us who are even you measure your sugar levels, isn't it? Yes. So how different is testing for INR? I think the question for us is the education that we need to give our patients. If they can monitor their INR and have an interface, a form of telemedicine, they can be able to reach. Summary stand up. Summary is at the heart of RHD care unless of RHD on top of Dr. Amy and a number of Muchu and whatever, but as a nurse, she's really the one, and she's passionate. And I think that this is a technology that ED we need to push for, because people are coming from very far, and probably this is the reason why they are prescribing for themselves summary, that they are not able to test, or they test infrequently, and when they test, they see that it's very low, so they adjust for themselves. Number one, they are poor, they can't travel here. But if we make it easier for them, they have the test kits, they can report. And I hope one time Isaac will share an interface which we are developing for management of heart failure over the telephone. This is something that we can expand for RHD care, because it's chronic care. And people need to really take charge of their health. So after surgery, doing wonderful surgery, they can monitor their NR, and we give them education that this is the acceptable range. If it's beyond this, on a couple of, on this test, talk with your doctor, and then we can guide them through that process. I think it's possible. Thank you.
Thank you so much. Hello. Thank you so much. My first question was about long-term follow-up. I wanted to know what happened long-term. And our study mainly looked at short-term outcome. We looked at Saturday mortality and morbidity because we could not do long-term. It would be a very big study. Otherwise, these patients, after surgery, they need follow-up because some of them may have some long-term outcomes which may need to be assessed. Especially these children may have arrhythmias which may develop, and also they may need other on top of the initial, especially patients who have patch repair may need to get a valve in the long run. So I think we shall look at these children also long term and see what happened to them. We could not do the whole short term and long term study at once. Then the survival rates over time, yes, I think survival rates has improved over time. Realize that the initial and currently things have the diagnostic modalities have we have improved skill in diagnosis, and I guess with all this the expected to improve. We didn't, in our study, we didn't look so much to look at the of these children. The outcomes in terms of the number I gave was overall morbidity in these children, which looked at infections, arrhythmias, prorefusions, among others, low cardiac output. So all these children, all these complications occurred, and that was which I gave. But the children who had only 20 of those children who had morbidities. And our commonest infection was septicemia, where we had only 10 of the 23. So it wasn't like all that. Thank you very much.
There are two online questions that we will request Dr. Aliku to answer. First is, thank you for the presentation, Dr. Aliku. You mentioned that RHD is a disease of the poor. Does this mean that developed countries like Europe and America do not have this disease? Second question, can you also provide us with the prevalence of RHD in Uganda compared to other poor countries?
Thank you for our online audience. If you follow the history of rheumatic heart disease, it was virtually eliminated in the developed world before the turn of the 19th century, before even the invention of penicillin, which is really the drug to use. Improvements in living conditions and access to general health care is really the driver for prevention of RHD. This is called primordial prevention. So largely in the developed world, RHD is still occasionally seen, but it's not at endemic levels like we see among our population, especially in the least developed countries. It is mainly driven by lack of access to better living conditions. That's most of it. And then poor treatment of sore throat and underdiagnosis of rheumatic fever, at which point you have opportunity to prevent RHD. In Uganda, and we've done several studies in Uganda, one out of every 100 school children in this country has evidence of rheumatic heart disease. So if you want to put it into perspective, that our average primary schools are about 500. So in each primary school, there is at least 5 cases of definite rheumatic heart disease. You can multiply it by the number of primary schools, but we know that from estimates 300,000 to 450,000 school-age children have rheumatic heart disease. Thank you.
Colleagues, the time has come for tea. So thank you very much, the presenters. Thank you very much, the audience, for being a good audience. I know there are questions that we did not take, so please feel free to interact with any of the presenters during the tea time. Thank you.
Yes, so at this point we'll have a tea break, and we'll have a working tea break. I believe that tea is being served outside. So just walk out through the door and have tea quickly, then we come back in and continue with the session. Thank you.
Hello. Yes. Say check. Testing one, two, testing one, two. Say check, check, say check, say check, say check. When,
Alimaka she did while in training in Canada. She has had multiple trainings all over the globe. So this is one of the work she did while in Canada, where there is heart transplant operation. We've not started heart transplantation yet, but we already have people who are trained in heart transplant. So when the program begins, we'll already have the human resource, thanks to the foresight of our executive director, Dr. Magino, and the chairman of the board, who thought it fit to have people trained in advanced cardiac care even before it is brought on board. So Dr. Namyonga, you're welcome to give us this presentation. Come forward.
Ladies and gentlemen, thank you so much for the kind introduction, Dr. Lubega. This was work that we did at the Stollery Children's Hospital at the University of Alberta in Edmonton in Canada in 2020. I clearly remember that cold winter of minus 40 degrees. So RV, or right ventricular dysfunction by echocardiography, is an early marker of evolving. There's what we call coronary allograft vasculopathy, and we're looking at this in heart transplanted children. Now, the Stollery Children's Hospital is the main center and the high volume center in North America for all cardiac surgeries in children. The ED has had an opportunity to visit the center, and all high-end surgeries are done there. I was glad to win a scholarship by the Stollery Children's Heart Foundation for this prestigious fellowship. So allograft vasculopathy, which we will abbreviate as CAV, is the leading cause of graft loss in heart transplanted patients after a long time. And it's clinically silent in children and asymptomatic, especially in the initial stages. An early diagnosis was quite difficult, because the modes for investigating were mainly used for coronary abnormalities in adults. That picture shows what typically happens in coronary arteries of adults and in patients, those who have coronary artery disease. I don't have a pointer, but if you look at the extreme upper image, that is what happens in patients who have coronary artery disease and they're adults. So the tissues, the vessels generally, the intima will swell and narrows the lumen of the vessel, of the coronary. But when they have CAV or allograft vasculopathy, it is concentric narrowing of the vessel. It's not unregular like the one that happens in the adult forms. So it's usually very difficult to identify in its early stages unless it is advanced. This is one of the papers that was published in the Heart Lung Journal of Transplantation, and we're looking at what happens after a patient has had a heart transplant. And we see that the color in green is the commonest cause of graft failure, and this was mainly higher in patients that had CAV, which is in red. So if a patient got allograft vasculopathy, they were more likely to have graft failure. And it is classified into 3 groups. Just like we look at other classifications, if they are symptomatic, it's CAV 0. And CAV 1 is when they have less than 50% of the main vessel. And then CAV 2 if it's more than 50% with one vessel, and CAV 3 if they have 2 vessels. Again, this gives us about the flow, what happens over years in patients that have CAV. The graft survival is limited over years in the presence of coronary allograft vasculopathy. So the gold standard for diagnosis and detection is is angiography, not annual, forgive me for that typo, is the coronary angiography, which is having very low sensitivity, especially in the early stages, and it is invasive in children and has limited applicability. So we thought of using echocardiography, which is the tool that we have at our display all the time to pick out children that were likely to have failure of or likely to have this disease. And we used deformation imaging, which includes myocardial strain and strain rate. Dr. Zhang here has looked at strain and strain rate in patients with cancer to be able to detect those who will have cardiomyopathy. So the same thing, we looked at patients and looked at their strain and strain rate to determine whether they were likely to have early disease. So I'll go to the next slide. So our hypothesis was advanced functional echocardiography. Strain and strain rate would help us detect early ejection fraction, Simpsons, with deformation tissue imaging in children. So we got approval from we've not yet started storing echo images. These images had been stored from, say, birth for children from 0 to up to age 18. And what did we do? CAV diagnosis was based on the guidelines that have told us. We divided them into controls and matched them for age and sex, for underlying diagnosis and the time of post-heart transplant. They were labeled as control for CON or pre-diagnosis. This is 6 to 12. It's a software that comes with the Philips machines, echo machines. It's a software that you can use to analyze this data. We don't have it yet in Uganda, but we've been pressuring people that supply us with equipment to give us TomTech to be able to analyze and detect early cardiovascular disease. So this is what we did. We compared the ordinary methods of LA volume, ejection fraction, RV fractional area change, the mitral valve, E and A velocities plus A prime, and S prime, to look at how these chambers were reacting before the children got the actual disease. 145 patients had had heart transplants in a period of 10 years at 10 years. So CAV patients who had coronary allograft vasculopathy had reduced right ventricular longitudinal strain. We assessed all the strain on the LV and RV. So we picked out what was significant. And strain is graded as a percentage, and it's graded as negatives. So the ones who had CAV had a strain of 12.1% vis-a-vis the controls who had a 21.5%. We used positive figures, but it's usually rated as negative, and this was significant. And we also noticed that even 6 months before the disease, they still had showed signs. I think that's the next slide. So they also had reduced RV strain rate if one had CAV, and that was also statistically significant. The conventional parameters that we use every day in our echo labs cannot detect early cardiovascular risk, and this method can do for any hypertensives. If we looked at patients with hypertension and we look at all these parameters, we could detect people who are more likely to get, say, heart attacks. Used in the right ventricle for patients who later developed coronary allograft vasculopathy. And this was still statistically significant. Even their strain rate was reduced, as you can see, 0.95% was still reduced and was present 6 months to 12 months before the real disease manifested. Again, the LV parameters were not statistically significant and did not feature at all in aiding detection of early disease. These are the graphs that show us really what I have explained. And this table summarizes the usual parameters we use in Uganda, the LV ejection fraction, and the mid. I'll point out the LV mid EE prime. It's a very important parameter that we found to be very high and present in patients before they got CAV at 9.3. It tells us that they are high LA pressures. It's a very good parameter. And then in patients who really had established disease, it was markedly high. The RV fractional area change is a test that can be erred on by several people. If you do the inter-observer variability, it's usually very, very low. So we can't rely so much on RV fractional area change, and so because it was low, it means this patient has RV failure. It's not a very good parameter. It gives us some figures, but the inter-observer variability is quite high. But the strain rate and strain were really significant. So in summary, RV global longitudinal strain was markedly decreased in patients who had CAV, and this was also present 6 months to LV. It was also outstacting patients and modifying medications for patients who have had heart transplants so that they don't develop disease early. It is also important, for instance, in Uganda, we will say we don't have heart transplant, but we can actually do similar things to detect who is likely to have maybe RV failure or LV failure before surgery or after surgery. Thank you so much for listening to me, and thank you for the people that facilitated my training at the Stollery.
Time. Thank you for being a good timekeeper. Ladies and gentlemen, I have a co-chair who is Dr. Ndagire Emma. Is in another meeting. So those two are under training for interventional cardiology. And allow me to welcome Dr. Aliku, who is going to give us a presentation related to pediatric interventional cardiologist in detransposition of the great arteries. Dr. Aliku.
Is it on? Yes? Huh? Is there, huh? Sorry, let's see using the other one.
No, it's just.
Heart Institute over the last 10 years on the outcomes of patients with detransposition of the great arteries following balloon arterioseptostomy. Detransposition of the great arteries is one of those critical, time-sensitive cyanotic heart diseases. In this disease process, the aorta comes from the right ventricle and the pulmonary artery from the left. It means you have a parallel circulation. It means that the deoxygenated blood will be on its own and the oxygenated blood on its own. For you to survive, you need mixing. The best mixing is done at the atrial level. So many patients get born with restrictive interatrial septum, and we have to enlarge that, survive the first few days of life. But that's not the end of the story. After that emergency procedure, patients then need to go on to have definitive surgery. This surgery, the standard of care is on my left panel. Let me see whether I can get this. Yeah, on my left panel, you're unable to see, but on my left panel, arterial switch procedure. This is the anatomic correction, and then, but this one must be done within the first month of life. Otherwise, the left ventricle, which is programmed to support you for the rest of your life, sustaining even severe hypertension many times without giving up, may fail to switch on the molecular markers to drive that process. So if within 1 month you're not operated, then you have a second best option, which is the atrial switch procedure. The concern here, of course, is that you will have a risk for RV dysfunction. The good thing is that this disease can be detected in utero by fetal echocardiography. So if you recognize it in utero, you can be delivered near the Heart Institute. You can call either the two of us plus those up-and-coming people. We give you extra years on earth. Okay. So objective was to describe the long-term outcomes of patients after this balloon septostomy. This was a retrospective chart review. We included all patients with TGA who underwent this procedure of balloon septostomy from January 2014 to June 2014. And we called the parents to update on the status. Our cardiac catheterization registry is approved by this procedure. I don't know whether these ones will play. They are not going to play, unfortunately. But we widened that atrial septum, which is very restrictive. Oh, okay, there is a time delay. By a balloon, we dilate with a balloon and pull it across, then you get good mixing for this otherwise little condition. So what did we find? Over the 10-year period, we have 30 cases. This disease mainly affects males. The male to female ratio was 3:1. You can know the implications of that in our culture. The median weight, the mean weight was 3.3. None of these people had a prenatal diagnosis. So it has implications for us in terms of policy. Newborn pulse oximeter screening, because mean saturation of these people was 56%. So if you just measure the saturation, you can get this diagnosis. And each pulse ox is only 200,000. EDIT is only 200,000 Ugandan shillings. Okay. 97, all our cases were done by the local team except one. This really underpins the teaching in medicine. See one, do one. See one, do one. Dr. Lubega did the first one, and then he taught me, and we've continued, yeah? The associated echocardiographic findings, 73% of our patients had intact ventricular septum. Usually 50% will have a VSD, but majority of our patients have intact ventricular septum. That gives an impact in terms of the speed at which you must intervene to save these lives and prevent the left ventricle from sleeping too much for life. Okay. None of them had pulmonary stenosis. In this condition, if you have pulmonary stenosis, it offers a resistance to this left ventricle. So this left ventricle will not decondition, will not sleep, and so you buy more time. But in our patients, for us, congenital heart disease, regardless of the population count at birth. So usually TGS account for 5 to 7% of all congenital heart disease. So knowing that in Uganda we have about 16,000 babies born with congenital heart disease, 5% of whom should have TGA. We expect 800 cases per annum, but we are only able to do 5. Only 5. That means we are working on less than 1% of cases who have TGA. This, where it is colored, this is where the patients come from. The darker the color, the more the number of cases. You can see that all these cases, majority of them are clustered around Kampala. It does not mean that people from Soroti are not having children, or people from Imbale are not having children, or people from the oil region are not having children. The implication is that actually access to diagnosis is very scarce in our country. Something you can screen with 200,000, a gadget of 200,000. Age at the procedure. Age at the procedure. Our median age at this procedure was 29 days. That means 1 month. 1 month. This is the median, which is very late, as I'm going to show you. And this is the distribution. Only a quarter of our patients are operated in the first week of life. What is the important thing? 28% have died by 1 week. If you do nothing by 1 month, half of them have died. If you sleep for a year, 9 out of 10 will have died. All right. Our immediate procedural outcomes were very excellent, determined by improvement in saturations. Remember I told you the mean saturation was 56%? After the procedure, the mean saturation was 77%. Usually after the procedure, we expect it to be between 70 and 80%, which is very important for neurological development, which is the resource for this country. Human capital, the brain is the resource for our country. You know that, huh? All right. Okay. How about access to definitive care? Only 13 patients out of our total were able to access surgery. And most of the surgery was arterial switch, which is where our cases operated from. These are the countries. Uganda, we operated on 1 case, only 1 out of 29 per what? 29 cases, only 1 in Uganda. And remember, this is a case which needs what? Emergency what? Surgery. Most of them from India, some from India and abroad. Of course, our partner Chain of Hope helps us, especially in Western Europe and Egypt. They've been helpful. So what are the implications for surgery? Only 40% have access, less than 10% done locally, and most of the surgery is physiologic, not anatomic repair. Median age at follow-up, so we follow these people from the time of surgery. Median age at follow-up, at the last follow-up was 28 months. Of course, high loss of immediate outcomes for BAS are excellent. There's lack of access and, of course, loss to follow-up. So what are our policy recommendations? We need guidelines to promote, to improve prenatal screening and diagnosis. Many of, actually, probably 90% of our women, when they are pregnant, they have at least 1 ultrasound scan. At least 1 ultrasound scan. During that time, you can screen for this. And then, of course, if
and attending Uganda Heart Institute, and this is none other than Dr. Gloria. She's very, very energetic. Very energetic. She grasps ideas quickly, faster than most of us, and we are really very, very hopeful that she'll make a very good pediatric cardiologist in future. So, Dr. Mugisha, you have your 10 minutes. Thank you.
Thank you, Dr. Lubega, for that very kind introduction. And this is a study I did during my MEd. And this was my MEd during my MEd. And this was my MEd thesis, and it was done under the supervision of Dr. Lubega and Dr. Helena New. So we studied delayed echocardiographic diagnosis of congenital heart disease and its associated factors among children attending the Uganda Heart Institute. So we defined delayed first echo diagnosis as a diagnosis beyond the ideal age for elective repair, according to the consensus guidelines for indications and timing of intervention for common congenital heart diseases. We'll see the application of this later on. We know that congenital heart disease is a leading cause of infant mortality, accounting for about 7% of neonatal deaths. And just like Dr. Aliku said in the previous presentation, we have about 14,000 or 15,000 babies being born every year, estimated to be born every year with congenital heart disease. Diagnosis is possible prenatally by fecal echocardiography and after birth by neonatal clinical screening and transthoracic echo. So in our country, Uganda, fetal echocardiography and neonatal clinical screening are not routinely done, which results in many newborns being diagnosed after discharge, and not just after discharge, but even later in life. So delayed diagnosis prevents the benefits of timely corrective surgery for congenital heart disease, but also increases the risk for complications, lifelong morbidity, and mortality. So definitive diagnosis by echo is important in determination of treatment of congenital heart disease. And in Uganda, the time of diagnosis of congenital heart disease and its associated factors were not known. So these findings will hopefully inform clinicians about the magnitude of the problem of delayed diagnosis of CHD and stakeholders in planning corrective actions to mitigate the associated factors. So the objectives of the study were to determine the median time of first echo diagnosis of congenital heart disease among children attending the Uganda Heart Institute. And at this point, we dichotomized the time of first echo diagnosis into delayed versus not delayed. And we determined the factors associated with time of first echo diagnosis of congenital heart disease. So we found out the factors associated with delayed congenital heart disease diagnosis. This was a cross-sectional study carried out at the Uganda Heart Institute between January to December 2021, and children who had a first echo diagnosis of congenital heart disease. We included those who had informed consent or assent for children greater than 8 years, greater than or equal to 8 years. We excluded children for whom cardiac intervention was not justified or indicated, and the relevant approval was sought from the relevant bodies. So we screened a total of 427 children with a first-time echo diagnosis of congenital heart disease, and having excluded 15 children, majority of them, 61.8%, had a cyanotic congenital heart disease, and it's at this point that we used the consensus guidelines to determine who of these children was delayed or who was in time for corrective surgery. So for the cyanotic heart diseases, surprisingly, the proportion in each arm was equal, although the numbers were higher, as expected for the cyanotic heart disease. So we had, so for the cyanotic arm, we had 42%, that's less than half being delayed, while for the cyanotic heart disease, we had more than half presenting with a delayed echo diagnosis. Overall, the proportion of delayed congenital heart disease for all of the children was 48.1%. So these are the characteristics of the children that we had. We had majority of children presenting between 1 to 12 months, that is after the age of 1 month. So if you follow Dr. Aliku's presentation closely, that could explain. That could be explained by the fact that some children do not make it beyond 1 month. For the sex, we had females being more. We had majority of the patients not having any dysmorphic features. 95% were referred by a health worker, and 3/4 of the children were brought within 1 month between referral. From the time of referral, they were able to access the echo within 1 month. And 64% of the children were from within a 100-kilometer radius. As usual, the most common acyanotic diseases were ventricular septal defects and patent ductus arteriosus, and the tetralogy of Fallot and truncus arteriosus were the most common cyanotic heart diseases. So the figure is a box plot showing the median time of diagnosis, which was 6 months with an interquartile range of 2 to 16.5. And the second figure is a bar chart showing that the majority actually presented after 1 month, between 1 month to 12 months. And after 5 years, that is after 6 months, the numbers really go very low. So we studied many factors, but we had 5 factors which were significantly associated at the multivariate analysis. One of them, which is maternal education above secondary level, that is any form of tertiary education, was less likely to be associated with delayed diagnosis, meaning it is a protective factor, while the other factors, delivery at a public health facility, absence of dysmorphic features, residence outside the central region, and seeking of alternative treatment before coming to the hospital. These are factors that were significantly associated with delayed diagnosis. And when we look at other studies that looked at this topic, our study has had a sample size of 412, which is comparatively large. We had a short medium time of diagnosis, and our proportion was relatively lower than some of the studies that had been done in other low and middle income countries. The one in Nigeria had a longer median time, but they did not study the proportion of delayed diagnosis. The one by Usman et al. In Pakistan had also a comparatively large size, but they had a really long time of diagnosis of up to 2 years, and they had a bigger proportion of delayed diagnosis. A study in Indonesia also had a longer time of diagnosis, but not as extended, as large as the one in Pakistan. The studies in East Africa looked at mean, and they did not study the proportion of delayed diagnosis, which made it challenging to make a comparison. So we thought that maybe many factors could contribute to our proportion being lower. Part of it could be that many children are not making it to the time of diagnosis. They could have died earlier. Secondly, UHI is lucky to be surrounded by a good number of referral hospitals, so most of those patients make it in time, but there could really be many more factors. In developed countries, we can see that the difference is really huge, because if you look at these numbers, most of them are around 10%, so only 1 in 10 children present with delayed diagnosis. So these are countries in which the fetal echocardiography is largely abundant, and the newborn clinical screening programs are really robust. So this could be one of the contributing factors to them having lower proportions of delayed diagnosis. So these studies did not look at median or age, because really much of the diagnosis was done within maybe days or weeks of birth. So looking at the factors that we found to be associated in previous studies, maternal education has been found to be associated with a less likelihood or a protective effect as far as delayed diagnosis is concerned, and that was shown in studies in Pakistan and the USA. And we thought that this could probably be due to health-seeking habits of maybe educated mothers, but also ability to recognize danger signs and follow through with referrals in case those are made. We found that the type of the health facility of delivery, that is public versus private, was so being delivered at a public health facility was associated with a delay in diagnosis, and we could not fully explain this, but we thought that probably there was a correlation with the socioeconomic status. We did not find any studies that had examined this association prior. Studies in southwestern Uganda, Belgium, and USA, children with dysmorphic features are less likely to be delayed, because then health workers are able to identify them and quickly refer them for for echocardiography. And we know that in our going to the church and also traditional alternative medicine, this is one of the things that caused the delay. In previous studies, this association had not been studied. However, in a study by Usman et al. In Pakistan, found that most reason for not visiting the health center earlier, a health facility earlier. And this, the region of residence outside the central region or long distance for some of the other studies has been found to be associated with delay, and this was also found to be significant in our study. So that's the influence of health workers on the time of diagnosis. In conclusion, the median time of diagnosing congenital heart disease in Uganda was 6 months, with majority presenting between 1 to 12 months, and almost half of them were delayed. Delayed first echo was significantly associated with maternal education below tertiary level, delivery at a public health facility, absence of dysmorphic features, residence outside the central region, and alternative treatment sought before visiting a health facility. We recommend active cardiac screening and pulse oximetry for newborns before discharge from the birth facility, health education for the public. But
much Dr. Gloria Umugisha for that presentation, who is a pediatric cardiology fellow. Ladies and gentlemen, at this time, I'd like to invite our chief guest, Dr. Jane Ruth Acheng, who is also a pediatrician, and she's a Minister for Health and also Woman MP for Lira City. You're most welcome, our guest of honor. I'd like to request all of us to stand up for the national anthem of Uganda. So we'll have it played and we can sing along. Thank you so much.
Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike, umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Yes, thanks. At this point in time, I'd like to invite our dear Executive Director, Dr. Magino John, to come over to give a few words. Then he'll invite the board chair, who then will invite the Minister of Health. Thank you so much.
Is it good afternoon already? Good afternoon. Yes. So, good afternoon. Good afternoon. Yes.
our Honorable Minister of Health, no other than our own Honorable Dr. General, your hospital, in fact, churning it out. Now there is the second, the next layer. The hospital is working, and the rest of them, the next layer. The hospital is working, and the rest of them are there. The hospital is working, and the rest of them are there. But that is the next, promote people above. Those are the people who have finished their specialists. They are under roles. Arising from them is the messages that desire of equitable distribution of services up country. Yet the incidence of heart disease, for example, the children, is the same all over. It doesn't, one has to answer, why are there no children from Kabale? Why are there no children from what? Moroto? Why are there very few children? The answer is the children are there, they are born, they have their problems, but they need the what? The service. And the Heart Institute is here to answer that. It is given the data, and now it has also given the plan for more research, but also in the strategic plans that are coming, or the national development plans, many of these centers must be opened. And I have to tell you, there's a scramble for these services. As we talk, somebody came, one of these people who are coming from the regional centers have come with letters confirming that they have land, they need their centers developed. And yet in the National Development Plan 4, they only captured 4. We want your guidance and strength, and you must put there your blood to ensure that we start with the 5, really inclusive. So we have to change or to modify that National Development Plan 4 to include at least 5 regional centers. To construct those centers, the demand is there. So having said that, the rest is to present to you, we shall give you a summary of this, Congress, but the issues, those are the key things coming out, which need policy formulation or to be supported by policy. The other issue, be proud, work is being done at that international level. The issue is, going forward, we have contracted a team to map capacities. In fact, let me even put this, don't wait for it. We want a deliberate move or policy by government to support specialist training, and this is what we need as scholarships to support specialist training at the universities. And then part B is scholarships for fellowship training at the Heart Institute. And mark you, when we do fellowship training, it is for 3 years. We get a master's holder, we handle him for 3 years. She may not be there. Training, and then come out to earn very little. No. The issue is we have to be deliberate. Having said that, I take this singular honor to invite the board, chair to say something to you. Thank you.
Honorable Minister of Health, medical schools, staff of the Heart Institute, the very key people here, the researchers, distinguished guests, press, ladies and gentlemen. It's a great honor and a privilege to stand before you today as we convene to reflect upon and celebrate and share the progress, the learning, and the impact of cardiovascular research at the Uganda Heart Institute. Today's gathering is a moment of collective appreciation. It's a time to take stock of where we have come from and to acknowledge the strides that we are making and to recommit ourselves to the noble vision that continues to drive our work. As we celebrate the milestones achieved through research, which have already been presented and some that are going to be presented the rest of the day, the Heart Institute Board takes great pride in the professionalism, the diligence, and the intellectual rigor demonstrated by the Institute's researchers and clinicians. And I just want to say, Honorable Minister, that the work we've seen this morning, the quality of the work we witness is the result of long hours, careful study, collaborative effort, and above all, a deep sense of responsibility towards the health and well-being of our population. These accomplishments are built upon a strong institutional framework that emphasizes ethical standards, sustainability, and alignment with the nation's health priorities. Over the years, Uganda Heart Institute has steadily earned the confidence of the government, development partners, and the wider scientific community, and that's why you see there's a good representation here. And most importantly, the communities that we serve. This is a hard-won trust, and it reflects the Institute's unwavering commitment to accountability, to transparency in decision-making, prudent resource utilization, and a readiness to respond to the emerging health challenges with both urgency and competence within the limits with which we've been confined in. And at this point, I'd once again like to thank you, Honorable Minister, for the support that you've given us as we've sought to advance the vision of the Heart Institute. We've got good support from the ministry. Thank you very much. Ladies and gentlemen, cardiovascular disease remains one of the leading public health threats, both globally and here at home in Uganda. It accounts for about 10% of annual deaths in the whole country. This is a very sobering statistic that speaks the magnitude of the challenge that is before us. Our population continues to face a growing burden of hypertension, congenital heart diseases, rheumatic heart disease, and other cardiovascular conditions. These conditions affect not only individual patients, but families, communities, and ultimately the nation's human capital and economic productivity. And these pressing realities reinforce the importance of ensuring that our research efforts are not just academic exercises to get the next qualification, but are rooted and relevant to the action that is needed to address the challenges we have in the country. And I'm glad to say that the research I've had this morning is very relevant. It's about work that is being done in the country on addressing the needs of the country. Research at the Heart Institute must continue to inform national health policy, and I'm again very glad to see that all I've had this morning, I think almost all have had a policy element. Because it's one thing to have these nice documents on shelves, but so what? They must translate into policy, into things that clinical protocols as well, and optimize resource allocation and support the continuous development of cardiac care services. As a board, we remain fully committed to this vision and ensuring that every study, every analysis, and every recommendation contributes meaningfully to better patient outcomes and stronger health systems. And I trust that as we come to the end of our tenure, the new board will pick it up and advance it. I take this opportunity to commend the Executive Director. Thank you very much, Dr. Magion and your team. Your resilience, commitment, and professional excellence continue to define the Institute's growing reputation, not only within Uganda, but across the region and globally. I'm not aware of any other place in this region where such a meeting takes place. And as the Executive Director said, continuing on this path, we are well on the path to becoming the center in the region and probably on the continent. I know there is Egypt and South Africa to look at, but certainly this is becoming one of the go-to places when it comes to cardiovascular disease and health. I also wish to sincerely acknowledge the indispensable role of our development partners. Their financial, technical, and moral support has provided the necessary scaffolding upon which much of this work has been built. And without their partnership, many of these research milestones would have remained aspirations more than achievements. To the patients and families who have participated in these studies, allow me to say that you are the true heroes of today's celebration. Your willingness to contribute to scientific inquiry, sometimes at great personal sacrifice, has allowed us to generate evidence that will benefit countless others. And your participation is an extraordinary act of courage and generosity, and we remain deeply grateful. Ladies and gentlemen, research is not peripheral to the mission of the Heart Institute. It is very central. And as a board, we are committed to ensuring that a conducive and enabling environment for research continues to thrive. And this requires not only sound governance structures, but also vibrant strategic partnerships, strong institutional capacity, and effective monitoring and evaluation systems. These pillars will ensure that research findings are not only published, but are translated into policies, protocols, and practices that directly improve the care we provide. We are also committed to fostering strong collaboration with the Ministry of Health and all relevant stakeholders, and I think that's very evident today, judging from the representation, to ensure that research outputs remain aligned with national and global health priorities. Through such collaboration, we'll continue to strengthen the bridge between research, clinical practice, and policy formulation, ensuring that fruits of scientific inquiry are felt at every level of the healthcare system. In closing, I extend my deepest appreciation to you all, researchers, clinicians, administrators, partners, and participants, for your contributions to this important work. Today's Research Dissemination Day is a reflection of what has been done, but also a reaffirmation of the journey ahead. May we continue to be inspired. I hope that what is happening here will inspire the medical schools, will inspire every other place. And this is how we lift the standard of care as we set places of excellence and hold hands to move our country forward. So may we be committed as well and united in our pursuit of excellence in cardiovascular research and care for the benefit of our people. I thank you all, and I wish you all a productive and impactful Research Dissemination Day. Thank you very much for your attention, and it's now my singular honor to invite the Honorable Minister to address us. Honorable Minister.
John, you can sit down. The Chair and Board of Directors, Uganda Heart Institute, the Executive Director, Uganda Heart Institute, our partners present, the staff of the Uganda Heart Institute, the various universities presented, distinguished guests, members of the press, ladies and gentlemen. Good afternoon to you all. Let me first of all start by apologizing for coming late. Like you heard from John, the color that I have on will tell you what is happening. It is a mess out there, but somehow I managed to sneak through. Thank you very much for waiting. I appreciate. 1 year ago, we gathered to launch what is now a cornerstone of Uganda's cardiac research ecosystem, the Uganda Heart Institute Research Dissemination Conference. Today, we reconvene not merely to reflect on progress, but to affirm how Ugandan science is actively reshaping cardiovascular care across the country. The Uganda Heart Institute has long stood as a center for innovation and excellence in cardiovascular care. I am very much aware that behind every scientific breakthrough is a team of dedicated researchers and clinicians, men and women, whose relentless work enhances our understanding, refines treatment, and ultimately saves lives. Each data set analyzed and every clinical insight gained represents an opportunity to transform a life, safeguard a family, and strengthen our entire health system. Every time I stand before you, I recall what the Uganda Heart Institute was several years ago. Several years ago, I think very few of us here can remember, perhaps the director himself, a few of the senior consultants who stood up, and my OB here. You remember what the Heart Institute was on 1C. I think it had very few beds. It was not what we would call a heart institute. But really we must thank those who stood and fought for a heart institute. I recall the days when I would go with John to defend before Parliament why we needed a heart institute and why we must be given money. And one of those days we were insulted that it was a company limited by guarantee, and so it should not have money. So we walked out and we caucused. We call it caucusing. And we agreed to let go the limited component in exchange for money. You know, money is a matter of negotiation. But today, when we look at what the Heart Institute is and the research you people are doing, I think when John goes back, and many of the consultants here, tears fill our eyes. We have come a long way. And we cannot miss to say Ebenezer. Thus far, the Lord has brought us. So today we witness the real impact of research, its power to inform healthcare delivery, shape policy, and improve outcomes for patients. This conference plays a vital role in that process by convening key stakeholders, including policymakers, development partners, and the media, to help close the gap between research and practical application. I'm particularly pleased to note that the Institute has shared its research agenda as part of this year's program. This strategic move defines priority areas for innovation and also positions Uganda as a leader in cardiac research within the Great Lakes region and beyond. Let me also not forget to say that even my home district has participated in research. There's a long research that took place there. Yes, and many others. Not only research, even cardiac operations. So we are not hidden in the north. We are big and we are known because of you people. Thank you very much. To our researchers, your work is shaping the future of healthcare in Uganda. The Ministry of Health stands with you and is fully committed to fast-tracking your studies for timely implementation. Let me also add here that we stand with you to ensure that the other regional centers are put up. As I was coming here, I was whispering to the chair that this one is not for record, please. That the amount of money we are spending in politics could save so many lives. So many lives. But for the last few months coming, almost 8 months, it will be like you are forgotten. We shall be focused on politics. If only we could reprioritize and focus on what matters. Not that I don't like politics, but there are certain things that really matter, that you cannot forget even as you're doing politics, and that is life. Because it could be me or it could be you, and we need to save lives. But I only whispered that to the chair. I didn't whisper to Dr. Magino, because he could have turned it in another way. In 2024, we proved that Uganda can produce world-class research. In 2025, we are proving that this research can transform lives. As we engage in today's discussion, I urge all of us to think critically, collaborate courageously, and leave this conference not only informed, but empowered to act. To every contributor in this room, thank you very much. Thank you for the time that you took to do the research, and also for willingly sharing your information. Your work matters deeply. Let us continue to invest in our scientists, deepen our collaborations, and ensure that research leads to real, tangible benefits for the people of Uganda. The world is watching. Ugandans are also watching. Let us show them that our Ugandan science, as we have done previously before, Ugandan scientists have always excelled. So let us show the world that we are true Ugandans from the source. I thank you, and I say all this for God and my country. Sorry about, sometimes when the meeting is already opened, you fear to add other words. But since I have been given the authority, it is now my honor and pleasure to declare the UHI Research Dissemination Day officially opened for God and my country.
Thank you so much, our dear Honorable Minister of Health, for those words. I think the sky is the limit for us at this stage, such support that we have. At this point in time, we'd like to have a group photo with our guest of honor. So I'll invite the Vice Chancellors of universities and also the directors of hospitals, of Yumbi Hospital, Women's Hospital, Mulago Hospital, Fort Portal Hospital. Please come forward for a group photo before we continue the program. So Professor Ikojo, Mwini University, Yumbe Universal Hospital, Director, Fort Portal Hospital, the Women's Hospital of Kampala, Kabale University, so I think we should come down for the photo. Let's come down on the lower podium for the photo. And let's have the board members as well coming in for the photo. Okay. I have been duly informed that our dear Minister of Health, after the group photo, she will be leaving for another engagement. You come down. You can come down. So our dear Minister of Health, our guest of honor, the board members, the Vice Chancellor of universities, all hospital directors, you're most invited for the photo. Photo, please. Let's have the senior consultants joining. Senior consultants kindly joining. Senior consultants and associate consultants. Senior consultants joining. Dr. Mwambu, Mr. Kecho, Dr. Lubega, Dr. Liku, Dr. Tumwebaze, Dr. Magala, please come join in for the photo. Yes, the consultants, please join. Dr. Lamek, please join in for the photo. So after this photo is taken, we shall have those who have just completed their fellowship programs in adult cardiology, pediatric cardiology, and also the current fellows to join in for the photo. So Dr. Miriam, okay, Vice Chancellors can come on once again. Vice Chancellors, then after that, we'll have the students, the fellows, and those who have just completed their fellowship training. Vice Chancellors, deans, faculty members for universities, please come on. And all heads of institutions are welcome. let's have the research committee come stand nearby here as well so they can meet our guest of honor. It's the research committee. Fellows are coming. Then. So fellows, Dr. Doreen, Dr. Miriam, please come for the photo, please. Dr. Sempira, you come forward here for the photo briefly.
We're now having the fellows. After the fellows, we'll have the fellows. We'll then have the research committee right after the fellows. The research committee, hope we are ready. Research committee. After the research committee, we shall have the research agenda team. Yes, we are now having the research committee.
So the last group we'll have will be the research agenda team. So Professor Biamugisha, Joseph Alt, and your team come forward. This is the last group for the photo. So research agenda team, please, you can go for the photo. Our dear guest of honor, Dr. Jane Luther Cheng, we thank you so much for gracing this occasion. We thank you for making time to be here for our presentation today on our research dissemination and research agenda conference day. We've had many presentations. The program still continues this afternoon late. So they are taking a photo with our abstract book for today. I hope you all have a copy of that with yourselves. And also our research agenda that's been given to our dear Minister of Health, which lays a yardstick for us to do research and to produce research that is very productive. Our dear Minister of Health, thank you so much for coming. We are very glad, we are honored. You have come from far. She remembers the Heart Institute a few years ago was only a few beds and a few rooms, but in the near future, it will be a multi-story building with a number of operating theaters, and the future cannot be brighter. So at this point in time, we'll continue with our pediatric cardiology sessions, chaired by Dr. Lubega. Doctor, you're most welcome to continue.
Dear colleagues, ladies and gentlemen, I want to welcome you back from the opening ceremony. We are now back in the scientific program. So I want you to align your minds and brains to this scientific session, which is continuing. I want to remind you that we are in the pediatric cardiology research papers. That's where we were before the Honorable Minister came in. The session had 4 papers, of which 3 were already presented. We are now going to the final and last presentation. And I just hope that we still remember our questions that we wrote down, because after the 4th presentation, we'll go into the Q&A. So I hope you didn't lose those questions that you jotted down. The 4th presentation is on the cost of school screening for rheumatic heart disease and the cost comparison of alternative strategies for confirmatory echocardiography in Uganda Heart Institute. And this is supposed to be by Dr. Jocelyn Rabembera, who, because of gender balance, chose that she'd be represented by Mr. Pole Jaffes. Mr. Pole Jaffes, as he comes, allow me to introduce Mr. Pule Jaffes. He's the program lead scientist for the Rheumatic Heart Disease Research Collaboration at Uganda Heart Institute. He holds a bachelor's degree in nursing and a master's degree in public health, and is currently pursuing a PhD program. He's working with the research unit of Uganda Heart Institute, which will be growing to a research department in the new home, the 250-bed new home in 2027. He will be part of that department. It's now a unit where he works. Mr. Pule, you're welcome to give your presentation. Thank you.
Thank you so much, Dr. Lubega, for that kind introduction. I'm privileged to present Dr. Rebembera's study, which, as part of the rheumatic heart disease research group I'm also part of. Apologies from her, she couldn't make it here due to travel and other assignments. So this is about the cost of school screening for rheumatic heart disease and the comparison of alternative screening strategies and different confirmatory methods for echocardiography in the field. And we'll see what that means in a bit. As a background, rheumatic heart disease that everyone has been talking about and that we've heard a lot about is an interesting disease. We've heard from the previous presenters that it's a disease of the poor and other things. But let me interest you in this map that shows you the parts of the world where it's endemic. And Uganda is one of those. And currently we have, figures, staggering figures, more than 55 million affected and over 370,000 deaths happening annually. So this is the natural history of rheumatic heart disease. Again, as a way of background, it starts with a sore throat, a group A strep infection, which is usually a sore throat, and this, in some people, progresses to rheumatic fever, which is an autoimmune reaction of the body, and this is characterized by joint pains, fevers, and many other systemic symptoms which disappear or go away within a few weeks. They resolve. But the damage to the heart, which is carditis, persists in some and progresses to rheumatic heart disease, which starts as early rheumatic heart disease. And at that stage, you can see with the picture below that in early rheumatic heart disease, patients do have, mild, they do not have any symptoms at all, clinical symptoms, but they have on echocardiography mild regurgitation and mostly regurgitation at the aortic valve area. So this, over time, usually 1 to 10 years, progresses to advanced stage of the disease with severe regurgitation, and symptoms begin there. And then there's end-stage disease where patients are very sick and eventually they pass on. However, it's important to note that between early rheumatic heart disease and advanced stage of the disease, there's opportunity to intervene. And unfortunately, most of the patients that we see, they present with late stage disease or advanced disease, and we have very few options for their treatment and interventions like surgery. So what can we do between that early stage of rheumatic heart disease and advanced stage of rheumatic heart disease? It's interesting because, like other presenters have talked about, echocardiography being a powerful tool at our disposal that we can use to diagnose disease. In early stage rheumatic heart disease, we can actually diagnose rheumatic heart disease early, and the World Health Organization recommends that people are screened at population level, and this is in the most recent guidelines released in 2024. And so it's important to see what this would cost in general. There is some literature around the cost of echo screening at population level, and these studies are mostly from other countries like Brazil, Australia. But it's important that we get context-specific costs, especially for Uganda. And the aim of this part of the study that Dr. Jocelyn is undertaking as part of a PhD that is hosted at the Department of Internal Medicine at Makerere University is to estimate the cost of screening and confirmatory echocardiography following the implementation of the 2023 World Heart Federation active case finding algorithm. And this is contained in guidelines that were released in 2023 at a World Congress for Rheumatic Heart Disease in Abu Dhabi, where many people from Uganda attended, including our very own executive director, Dr. Omagino. So the algorithm that the World Heart Federation put forward for active case finding is represented here. People without any prior history of acute rheumatic fever, rheumatic heart disease undergo screening, where then if they are positive, after being screened using a set of criteria, those with positive screens undergo confirmatory echocardiograms, and they are staged in those different stages for their rheumatic heart disease. So those different stages have different management, as the cardiologist will tell you. But now back to screening. From the screening, thank you. For the screening, we have different steps of screening when we go out, and this is especially looking at screening in schools. First, when a child is found at a school and undergoes a screening echocardiogram and it's positive, originally using the usual way we would do a confirmatory echo, but this would not happen at the school. They'd be invited, they'd be given a slip, they'd go to the parent, and they'd be invited to go to a hospital where they would then be confirmed. And this screening was done using different kinds of small handheld echo devices, and the confirmation is done with a complete echo or more complete study done with a more sophisticated machine. So recently, in a study where this study is nested, there is an ongoing clinical trial in Lira district in northern Uganda, where several children have been screened to date. I think there are over 40 or 50,000 school age children in the district. And what has been done there is integrating the confirmatory echocardiography on the same day at the school. So instead of having them referred to go to the hospital where the specialist would then see them, the specialists actually go to the field alongside. So this pathway was used to do costing. We did ingredient costing across or along this entire flow, and all the costs at different stages were got, and different sources were also used for quantifying some of these that were not straightforward. And this busy table shows you the number of things or the number of ingredients, because you want to know all the input, all the things you're putting in or you're spending on during a screening activity. So this table shows you screening in general, and how the screening is being done in the field is by task shifting, done by trained nurses in a defined, limited echo, guided echo, focused echo algorithm. And so what you have here is costs of different things, and you could focus on the last row down, which is total, and the total cost is 1.8 $1.25 for every child screened in school. And then for confirmatory echo, the comparison was made between the usual way, where you get children in the field and then refer them to the facility or to the regional referral where they'd be confirmed, and to your right is the Goli model, where you go with the cardiologist to the field. And you'll see that the cost drivers here include, the standard echo machine or the service itself, and the cardiologist's pay for doing this work. And you'll see the overall totals differ, that when you go with the cardiologist to the field, the total is about $20 per child confirmed, compared to $26 using the usual way. So you will see that there's a difference in costs presented in this table, where you'll see in summary that the total cost when you refer a child to the hospital is $32.5 and $19, and it's about $20 when you confirm at school. In conclusion, screening echo is inexpensive, especially when you harness the things we've been finding through our previous studies, like task shifting, which is, training other people that are not cardiologists, because we have very few in the country training nurses to do screening echoes in the field. And then the use of low-cost handheld devices like some that we have, like the Lumify, simple probes that are attached to a tablet that are easy to carry around and go with to the field. And then economies of scale. This means you're screening very many children if you go to a school, for example, or you're screening very many people if you were to go to a community, for example. And so the health system costs for confirmatory echo are similar when you look at them between the school and the hospital, especially because they are driven by the echo machine and the cardiologist cost that I mentioned. However, when you look at all that, it is still obvious that when you invite people to come to the hospital, they'll be incurring another cost to the pocket of those children or their parents at home for them to come to the hospital. And that imposes significant costs on the families that are a hindrance to this. Thank you so much.
Another round of applause to Pule, and I want to request all presenters to come to the front. Mr. Pule, come to the front for the questioning session. Dr. Aliko, Dr. Judith, Gloria, come to the front. We'll keep it short because lunch, I'm told, is ready. So just come to the front. Where's the microphone? Okay. So we'll take a set of questions, and then we'll have the responses afterwards. I'm not seeing any hand up so far. Is this because people have forgotten? Or, oh, finally, thank you.
Let me get started.
Okay, start.
Yeah, so I'm really impressed by the link now that you make with heart conditions and creating a very public health approach to all these interventions. Initially, I was wondering why the director was so excited to have the universities here. Now it's getting very clear to me, the connections. It now makes it even more relevant, seeing your presentations, that we need to connect with the peripheries of the country, since a lot of the services seem to be centered around Kampala and surrounding areas. Now, what touched me particularly is when you connected to neonatal mortality and those abnormalities. I am a public health specialist, and I love to work around health systems within maternal and newborn health. So when you brought the element, and I'm now referring to, yes, Dr. Aliko, when you did bring in the element of the campaign, your presentation was the campaign to go out there. I now get the connection on what we can do at a very community level and at a cost that is most likely to be affordable. As you say, the machine could be as low as 200,000 shillings. And I connect that again with the colleague who presented on the percentages that we missed in diagnosis. So nearly 50% are never got in time, and yet these things are affordable. So I see a future in which we can now start to work together. My vice chancellor initially said, I cannot go there because it's all about science and difficult things. You rather go and participate because I will not understand anything. I am happy he sent me. Now I see the connection and I see a future of real collaboration with the Heart Institute. So mine is purely a comment, but you can also comment on my comment. Thank you.
Thank you. We'll take a set of comments and questions. Is there anybody else? Let's first get from the people on the lower bench, you on the upper bench. So, there's a hand. There's a hand. Okay, let's get that. You can stand up and introduce yourself because we could have not had a chance to know who you are.
Yes, good afternoon, everyone. I'm Oscar Mwemeke, a medical doctor by profession. At least I have my in here, which is Dr. Museme. I'm representing Dr. Flavia Matov Chiwewa, who's the director of Makerere University Johns Hopkins Research Collaboration. So my question is to Dr. Ariko. As per antenatal visits that are recommended by WHO, should we push for fetal echocardiography to be done for pregnant women?
Okay, that's heard clearly. There's another hand. There's a hand here and a hand behind.
Thank you very much.
Okay. Yes, go ahead.
I'm Nakonyi Susan, a nursing officer at Uganda Heart Institute. The question goes to Dr. Gloria. Among the factors associated in the delayed first echo diagnosis, you mentioned public and private health facilities. The mothers may be after delivering from the public center, echoes are not done to make early diagnosis. Are there policies or implementations in your study that you recommended for the public setting, like maybe Kawempe Hospital, comparing to, for example, Women Hospital, such that they can follow and there are less factors, looking at the factor you addressed in your research? Thank you.
Okay, thank you.
Thank you very much, Chair. Moses Chirigwajo is my name, from Uganda National Risk Consumers Organization. We on the other side. In fact, at the very beginning, I was wondering, what do I mention about all this science? It was too much. But I just wanted to appreciate all the presentations. And I want to sing out the one by Dr. Aiku. He was clearly categorizing the policy implications such that when we go for our advocacy, I can easily say, this is A, B, C, D. Just imagine, I was reflecting on my honorable member of parliament. If he was to be here, could we pick any message? So it's time for us now to translate the good research products into simple messages that can easily be understood, and also to help the policymakers to make really acceptable policies that we all appreciate. So I just wanted to comment on that and appreciate for inviting me to this forum, but also to encourage that we should now be thinking of how best we can translate this into practical terms, and we do advocacy together. Thank you very much.
Okay.
Thank you to
all the presenters. I'm Dr. Umar Simpo, presenting the ED of TASO. My question goes to my teacher, that is Dr. Aliko. He taught me medical school from Good University. The question for that condition. Then the other thing is that in your conclusion, you really noted that there's lack of local capacity for such kind of procedures. I would be interested in knowing what USI is doing towards that. But otherwise, I appreciate the director, USI, for all the great work. This is really a very impressive progress from last year. Thank you.
Okay, there's another hand here, research agenda table. We're about to close the questions so that we can get responses.
Thank you so much. My name is Kwizera Christopher. I work with Uganda Non-Communicable Disease Alliance. My question go to Dr. Iko. On TGS, you did tell us about the survival rate post the procedures, but I realize you kind of became a little bit political. Maybe you could elaborate more on what is the period. The oncologist will tell you the 5-year survival rate. So could you also be a bit discreet, and we know that probably what is the time. Then, of course, the other issue you talked about was access to care, diagnosis, and then you also, of course, together with Dr. Gloria, you are talking about prenatal screening. You actually said that of all the cases you looked at, there was none that was there was no diagnosis done, prenatal diagnosis or screening. But now the question is, given that the survival rate or the success of the management would be better if we had the prenatal screening or diagnosis, or maybe within 1 week postnatal. So what are we doing as Heart Institute to ensure that people access the services? Then on the other one is on the probably the causes. Are there predictors? Maybe like family history, maybe the behaviors of the parents, and also the health condition of the parents, or even the environment in which maybe the parents are or they lived. So I also wanted to know that. Then finally, you both had recommendations. And when you look at the Uganda Heart Institute, it's the only institution that's mandated to manage cardiac conditions and in the country. And anything that happens, I mean, any problem, you are in charge of all the hearts, including your own and those of us here, even somebody in the corner. And so when you're making recommendations, you're making recommendations to who? Because eventually even the parliament will come and ask you, what should we do? So in this case, and I'm happy that maybe your research more or less is a kind of implementation research. We would be looking at the action points. What are we doing and what have you done so far to ensure that, because given that the problems are already known, people are not going to access the services tomorrow. We are 49 million plus, and we all have hearts, and the hearts are in your hands for you to care for. So we should be knowing what are you planning to do, because we may be training the specialists like we want to do, but how about the diagnosis and screening? Where is it supposed to be taking place? At what level of care? Do we have to, maybe, you talked about 200,000 shillings for the gadget that's required to do a screening. At what level of care are we supposed to put that? Because where we put the gadget, the 200,000 shillings may not be a problem, but who is going to manage this? Is it at the lower level? I mean, at the primary health care facility, is at the specialized level, is at the regional referral hospital? I want also to know the level at which the screening should take place. Thank you.
I think we want to take that set of questions for now. We'll respond to these in the interest of time, unless Dr. Ariaka, is there anything? I think we want to respond to that side. Okay. So I think that's the very, very last one, and then we'll have the response.
Okay, thank you, Chair. Mine is it factored in the calculations for the course? Thank you.
Okay, thank you. So I'll now go to the panelists. You've had questions, and I hope you've been recording questions which are falling under your area. And probably can we start with Dr. Judith? You can respond. And you also should comment about prenatal screening, okay? Specifically because you're an expert in that area. So just comment about that when you respond.
Thank you, Dr. Lubega. Maybe before I comment on the prenatal screening, it's just alarming that we had about 50% of the TGA babies dying in the first 1 month. And the old literature we had was 30%. I think that is in maybe high advanced countries where no intervention could have been done. So our case in Uganda, I think, is really bad. We have 50% of them die in the first 1 month and not 30%. And so that takes me to the prenatal screening. That, and someone asked about the antenatal visits. We can't recommend fetal echocardiography for all pregnant mothers. They are usually risk stratified. And in our antenatal visits, we usually have at least an ultrasound scan done in the first trimester, which is more accurate to give us the expected date of delivery and the gestational age. But if we do fetal echocardiography, it's mainly recommended at 20 weeks and for people that have indications. So number one, families that have had children with complex congenital heart disease obviously will need a fetal echocardiogram by week 20. And so all these families of the TGAs, tetralogy of Fallot, that is a primary indication. Then high-risk mothers that have gestational diabetes with poorly controlled HbA1c of above 7%. I'm just speaking a few. Those would really need. And then maybe a mother who had a fetus with congenital heart disease, irrespective of whether it was a simple, if the mother had, and maybe she had a VSD and was repaired, an ASD that was repaired, we'd obviously have to do a fetal echo for her pregnancies. And there are many other factors that I might not go through, but for the fetal factors, if a fetus has anything that is abnormal on the routine obstetric scan, maybe they've seen club feet, or they've seen a cleft lip or palate, or they've seen some abnormal faces or a wide sandal gap, for instance, those with Downs, those fetuses should have a fetal echocardiogram. So for the neonatal and women's hospital, I think it's very important that, one, we identify those fetuses that they've identified with congenital abnormal and high-risk mothers as a fetal cardiology. But we will submit it for the next financial year, so we have a registry. Few as we get, not many people have. So if we say do it at large scale, no, but we could do neonatal screening also at birth and just do the basic pulse oximeter, as Dr. Liku documented well with that Tanzanian study. We had an opportunity to review. So it's something basic that we could take on. Thank you.
Thank you, Dr. Judith, about that fetal screening. But we need to note that it's not available countrywide.
Yes.
We are not talking about obstetric scan.
Yeah.
You know, people confuse obstetric scan because they look at the heart and fetal cardiac scanning. Those are two different things. Quite often, children will complain that mothers will say, they screened my child and told me the heart was okay. But that was an obstetric scan. We are now talking about the fetal scan, fetal cardiac scan. This is different. I think that's very important for us to note, and thank you, Dr. Judith. Not many areas can do this service, okay? We have Uganda Heart Institute in Zambia and one private. That's where it can be done. But
Dr. Lubega, even our usual sonographers that do the obstetric scan will actually pick 50% of congenital heart disease if they just do the usual 4-chamber view.
They usually don't do, that's what we are saying.
So, but we
when you say obstetric scan, they look for cardiac activity commonly.
And
like
heart rate.
There's a heartbeat and the heart rate. That's what they look for. So if you're interested in doing fetal screening the heart, you must specify Okay? Fetal cardiac scan. Don't say obstetric scan. That one they look for fetal viability. And they look usually for the heartbeat presence or absence. And then the fetal heart rate. Okay? So I just wanted to make that distinction. So for gender balance, Mr. Pule, do you have anything to respond to? It's not on. It's not lighting.
All right, thank you. I'd like to respond to the gentleman that asked the question about if the costing, in the costing study of Dr. Jocelyn, integrated or incorporated the cost of counseling as is done during screening in the field. I must say that the approach that was used in this costing analysis is a societal approach. Like everything was costed, and the source of data was from programmatic documentation of the cost of the things that were ongoing. But procedurally, when we go to screen children in school, which is data that was used in this study, when we go to screen children in the field, the counseling is offered by the nurses. And this particular analysis incorporated the costs of the nursing service that was provided. And the nurses that do this work, together with all the staff around them, are trained to offer that on top of the task that is shifted to them to do focused echocardiograms to identify early rheumatic heart disease. Thank you.
Okay, thank you for that response. We'll now go to Gloria for your responses. I know Dr. Aliko has most of the questions we have fired to Dr. Aliko. That's why I'm making him intentionally the last.
Thank you, Dr. Lubega, and thank you all for your questions. Thank you, Dr. Judith, because you've answered a big part of the questions that were directed to the prenatal screening and newborn screening. I'll answer the question from Susan, which was talking about public facilities being delivery in a public facility being associated with a higher likelihood for delay. I think how public facilities, I hope I understood your question. I'll answer, then in case you're not answered, you rephrase. So I think the answer lies in really empowering health workers. I think Dr. Omagino had talked about that earlier. If we are able to have enough human resource in all of those places, accompanied by equipment, even something as simple as a pulse oximetry and newborn screening skills, the performance of public health facilities, I mean, that association might be greatly reduced. Then regarding the other factors that could have been associated with delay, the gentleman that asked about family history, parental behaviors, and environment, we try to ask about family history, but most of these parents they've not really had these services, so some of them don't. We've had a few families who have a brief idea of maybe family history of congenital heart disease running in their family, but most of these parents have not really accessed echocardiography or have not sought care for their cardiac-like symptoms. So even much as we try to find out about the relationship of family history, we were not able to get this information. Regarding parental behaviors and environment, this was probably about a 20-minute interaction with a parent. We were not able to go in depth to look at behaviors and environment. Maybe that would require a qualitative study with more, maybe different methods like focus group discussions or in-depth interviews. You asked about our recommendations. I think I'll just say a little, but I think Dr. Aliku will say more. Of course, as you said, we are the Heart Institute, but I'm aware that there is a strategic plan for all these things to be put in place. There's a lot of work being done regarding, of course, decentralization. So with the decentralization, a lot of these things will be able to be done. All neonates will be able to access newborn screening. Regarding the level of care, I mean, like at what level, what is the lowest level of care that this screening can be done? Even a health center 2 and a health center 3, health workers at these levels should be able to tell, because they can identify cyanosis, they can use pulse oximeters, and they can identify signs like difficulty in breathing at birth. So even a village health team member, actually, that is health center 1, village health team members should be able to identify and refer patients that are suspected to have congenital heart disease. Thank you.
Okay, Dr. Liku.
Thank you very much, Dr. Lubega, and thank you for your questions. Of course, whenever you're talking about maternal and child health, you know, it gets a lot of attention. And I will want to say in the outset that it's good we have specialists in that area, from Women's Hospital, Professor Kisha, and I hope that really this is a growing collaboration between the Heart Institute and the professional associations, especially OBS and GYN, because we can collaborate across different levels to have optimal outcomes. So really, I just want to say that if you look across our country, and good enough the experts are here, 97% of our women have at least one antenatal visit during pregnancy. Of course, the majority are late, then third trimester, so that they can book for place of delivery, so that they are not turned away or treated rudely by our health workers. But nearly universal attendance of antenatal care. There is already an opportunity for that. And unfortunately for our countries, that access to even obstetric ultrasound scan is at 30%. And yet it is recommended that at least they should have, I don't know, anyway, I don't want to say the words, but obstetric ultrasounds at different visits. There's goal-directed antenatal care. In the second trimester, between 18 to 20 weeks, is the anatomy scan recommended. So if, like Judy said, if a child, or a fetus has any abnormality, then that fetus heart should also be screened. Now that is the point at which you refer patients for echo screening. And this skill, as Dr. Judy said, can be taught. In the developed world, it's a requirement. Okay. The comments about policy implications, of course, all of us can play a role. I think this is it. All of us can play a role. One of our roles is to advocate for low-cost technology. If a fetus, a newborn screen can be done for every baby, and it is recommended before discharge at 24 hours. And I think the professor is here. The skill delivery, now delivery of mothers with a birth attendant in a health facility, is it now closer to 90%? Okay, between 80 and 90%. 91%, you see? So 91% of our mothers in this country are attended by a skilled health worker. So if you just incorporate a technology which costs 200,000, you can screen these babies before hospital discharge. Thank you very much. The question about one child, of course one child was done locally. This is a highly skilled surgery which needs investment in terms of training. And remember, this is a baby who weighs 2.5 or 3 kilos. 2.5 or 3 kilos with everything very small. So it requires a little more training. And good enough, our cardiac surgeons are on that path. We are not yet where we need to be, but at least we have started. And recently I pushed them to do one. But anyway, they did another. The other diseases, but at the beginning of that history, the outcomes were very what? Very bad. Very bad. But now, survival after heart surgery is probably 98%. Yeah? So let's get started. The key point is to get started. And how are we, Heart Institute? Of course, we are sending people abroad. Our Dr. Miriam has just come back, and hopefully we'll place people longer to achieve that. Finally, survival after the procedure. I reported to you that only one child died in the immediate postoperative immediate postoperative period because of jaundice and sepsis after the procedure. And then another one had surgery, which died, the one who died at the Heart Institute. 20% were lost to follow-up. Usually we assign that to the worst outcome. 40% of those who were operated were still alive, and we had contact, they were still alive at the last visit. Yeah, and this is something we can look on. Finally, recommendations to whom? It is to all of us. As long as you care for a patient, that patient may be having a heart, and actually all of them have a heart. All of us have hearts. So the recommendation is to all of us, but we know there are people, like our ED is looking for money. So in your hospital budget, at least put their pulse oximeter. Yeah. Thank you very much.
Thank you. I think the recommendation was talked to you about all of us as stakeholders. Some of you are fathers who run away from these mothers, or you have relatives. So we're all stakeholders. So don't say it's Uganda Heart Institute's responsibility. It is collective responsibility, and that's the systems thinking. It's all of us. We're all stakeholders. Everyone, even the mother at home, is a stakeholder. We can't leave this without Dr. Nabonya and Dr. Byamgisha making comments, because a lot has been talked about. You know, congenital heart diseases will affect anybody with equal prevalence, whether you're in USA, Europe, or Uganda. So it means we want some comments from Dr. Nabonya and Dr. Josephat regarding this issue that has been talked about. Where's the microphone? Pass to Dr. Nabonya and then Dr. Byamgisha to just make some brief comments to close this discussion.
Thank you very much.
Maybe it's not on.
Hello?
Thank you very much.
Maybe you can put the microphone close to your mouth. Sometimes it's not very sensitive.
It's not very sensitive. Good afternoon to you all.
Good afternoon.
I really appreciate being invited, first of all, for this research agenda dissemination. Thank you very much, ED, Uganda Heart Institute, and also for the whole team. There's so much that I've learned here and so much that we've heard. But I don't want to be between you and lunch. But I know that there's much more ahead. At Mulago Specialized Women and Neonatal Hospital, indeed, we do have a high-risk obstetric clinic where there are issues that are identified, whether with the mother or with the baby, they are referred to that one. And I believe this is where we can really start off from to build that area. We do have a fellow who is doing those scans. We have one in training, and we'll be taking another one for training in the next financial year. So I believe we are on the right track. Every baby who is delivered goes through a neonatal screen by a pediatrician. So I think there are some additional points that I've noted, the pulse oximetry. I think this is something simple, that's something that can be done, that would be helpful. So the collaboration between Makerere University, Uganda Heart Institute, and Women's Hospital would do us very good, and we are looking forward to that collaboration. Thank you very much.
Thank you.
Let me see where people can see me. Yes, good afternoon.
Good afternoon.
I'm Josephat Byamgisha. My name is, my background is obstetrics and gynecology, and I'm also director for Makerere University Hospital. Let me start with the statistics. Currently, antenatal attendance is at 97%, which means almost every mother is getting a chance to have interaction with health worker. Number of mothers who are delivered under the care of skilled people is 91%. It has moved from 74 to 91%. It is recommended, initially WHO was very silent on these scans during the antenatal period, but now they have come out very clear. And somebody needs at least 2 scans, ultrasound scans that is. And one of them is at 18 to 20 weeks. That is, and the reason for this ultrasound scan at 18 to 20 weeks is for checking for congenital anomalies, including cardiac disease. So basically what we need is to see how this can be implemented. You remember they revised the antenatal attendance, antenatal care from 4 visits to now 8 contacts. And so as a country, I think we need to move away from regularly saying that in the developed world they are doing this. Because when you check, if you see the surgeries that are being done, the science that is being shown here, what is so difficult? Is it the scan that is more difficult? Members, we really need to implement. Dr. Majuno and colleagues, we need to combine efforts and start looking at our people as equally important, that they should have an ultrasound scan at 18 to 20 weeks, and at birth they should be screened. Now, when it comes to the newborn, there are a number of tests we need to do, because there is cardiac. But for example, the other day somebody was telling that also some children need to be checked for hearing and other issues, so that at birth, all the babies should again be assessed as is done in the high-income countries. So members, we need to move from the stage of lamenting to a stage of action, because all these are doable. Thank you very much.
Thank you. I've really enjoyed chairing this session. It has been participatory. I want to thank you for all your contributions, your questions and comments, and I want to thank again the panelists. Let's give them a round of applause as they come down. Thank you so much. We meet again.
Thank you so much, Dr. Lubega Suleiman, for the moderation. Thank you so much to the panelists for your wonderful presentations. Indeed, they were delightful and informative. So at this point, we are going to look at one of our big agendas for today, and that's the Uganda Heart Institute Research Agenda. And I believe most of us have a book in front of us, which is white like this. As our dear director said, there was intentional purpose to have a team look into how UHI can thrive in research and fly. So we have a very wonderful team that has done this job, and this is led by Professor Gamugisha Josephat. We have Dr. Roy Mubuke. We have Associate Professor Dr. Robert Kaleswibula. We have Dr. Xavier Nsaba, Dr. Mukasa David, and then I have Miss Asimire Caroline and Miss Ngabirano Jacqueline. This team has put together a document that will foster our research such that each and everyone can come and participate in such activities. Both clinical team that is in accounts, a team that's in IT, everyone has a piece of this cake. So at this opportune time, I'd like to invite Professor Josephat Gamugisha to come forward with this team to present this wonderful document to us. A round of applause, please.
I can start. Okay, let me start because we realize that it's at a tricky time, but we shall try to fit in Executive Director, Uganda Heart Institute, Executive Director, Marago Specialized Women and Neonatal Hospital, the Vice Chancellors, Hospital Directors, members from academia, seen colleagues over there, members of the Uganda Heart Institute Research Committee, members of the Research Agenda, with me, distinguished guests, ladies and gentlemen, all you are in your very important capacities. you will allow us to share with you what we've been going through for the past few months in regard to research, capacity development, and agenda for the Uganda Heart Institute. We imagine each one of you should have got a pull-out. This is a summary, as you've seen on top. We have got a bigger document, which is about 35 pages, and we thought we could pick out these important points that can be shared. So on top of this, there is a summary. I will introduce the team. The members are here. I will start with colleagues. We have Dr. Roy Mubuke. Dr. Roy, please, you need to put up your hand. Those will be coming here. He's a senior faculty and researcher in the Department of Radiology and Radiotherapy at Makerere University School of Medicine, that is College of Health Sciences. Holds a master's degree in medical imaging from Cardiff University, UK, master's degree in medical education from Stellenbosch, and a PhD from Stellenbosch University in South Africa. Also postdoctoral fellowship in bioethics, research and ethics from Johns Hopkins University. And he was put on the team that developed research agenda for AfriHealth. AfriHealth is an African body that brings together academicians, researchers, and health professionals to develop research for the continent. Let me go to Robert Kadyesubula. Robert Kadyesubula has been working quite a lot with the Uganda Heart Institute. He's a consultant nephrologist and kidney researcher. He is head of the Department of Physiology at Makerere University College of Health Sciences. He has worked in kidney disease and hypertension in low and middle-income countries for more than 12 years. Low and middle-income countries members are what people used to refer to as the low resource settings. And when you check, those don't exist, because Uganda was also one time being grouped among those. He was elected as a fellow of the Royal College of Physicians, FRCP London, in 2024. And is an adjunct associate professor at Yale School of Medicine. He holds a PhD in epidemiology of NCDs, non-communicable diseases, from the London School of Hygiene and Tropical Medicine. And he's an education director for African Association of Nephrology. That is AFRAN. Let me say those few things about him. Now, some other colleagues. Xavier Nsaba Gassani is right over here. He's a behavioral scientist and a policy and health systems analyst. That's how he likes to be referred to himself. I have other members of the team. David Mukasa, Christopher, as you can see, is a medical doctor, and he's also specifically interested in minimal invasive surgery. You will note that he was initially working with Makerere University Hospital, but he's now been taken over by Soroti University as a lecturer in the Department of Obstetrics and Gynecology. So you have somebody you can really invest. Members of the team, we have, I should move the slides because there are other members here. Yes, Ngabelano Jacqueline is a qualitative data manager. We did a lot of key informant interviews, and we needed somebody to transcribe these, and she actively managed that. Then we have somebody, and please make sure you stand up if you are up behind there, and then Caroline Asimile, in charge of finance and administration. People need to see you there. Some of them are at the back. So that's the team of 7 persons that has been looking through this for quite some time. We must thank everybody because we've got maximum cooperation with the people we interacted with, the Uganda Heart Institute and the several other members that we met, especially the stakeholders and people who we thought had interest in research. We start with this. It is talked about a lot. Executive Director, the last meeting you even had a book. You are moving around with it. So, but now we say we have CAP 258. Which gives the Heart Institute a mandate to handle cardiovascular disease. Yeah, this is an extended part of the background, and it talks about the UH mandate and its functions. In this, it specifically refers about carrying out basic and clinical research in cardiovascular disease, and also an aspect of applying research and develop new techniques for heart patient care you hear the points are already there. And so Uganda Heart Institute is working within this mandate. And not only, for example, performing research, but make sure that the research is applied. And that's where the aspects of policy briefs and policy implementation come in and are brought on board. Also embedded in this National Development Plan, the NDP 4, is all reflected in this, and the Vision 2040 for Uganda. They are all combining in this and coming in as part of the background. So we have this big task. The Uganda Heart Institute has big task of combining all this, fulfilling your mandate together with national development. The overall aim of the research agenda is to provide a structured framework for prioritizing and guiding cardiovascular-related research activities, including evidence-based care. Members, when you talk about this evidence-based care, this is very packed. It means you can break it down into many other aspects of care. Then disease prevention and health promotion. And you will see all this being provided. So it is more than just treatment. We have an aspect of prevention and promotion. There are specific goals, and these include promoting excellence and innovation in research, tackling national, regional, and global cardiovascular challenges to create an evidence-based for addressing these challenges. So there is an element of the internationality to foster an inclusive, equitable, and diverse culture of research excellence and continuous strategic improvement. That is another objective, to leverage partnerships and collaborations to drive research and innovation. We'll keep elaborating more on this. And from the members that are here, you can see that this is already working. Issues of partnerships, collaborations, key and part of the objectives for the research agenda. Then translate and commercialize research discoveries for societal impact. So there are all these high expectations that we are also going to have in you. Members, the way we are going to do this presentation, we'll have other colleagues present the different sections in regard to how we are actively participating in the research. So, and in this regard, I would want to invite one of my colleagues, Dr. Loy Mubuke. Please come and handle the rest of the sessions as we join in with other colleagues. Thank you.
Thank you very much, Professor Byamugisha. I know we are towards lunchtime. I won't take long. I'll take 1 or 2 minutes, and I invite David to continue. I would like to thank the director. I've seen quite a number of some people here who are doing PhDs. I sit on the School of Medicine Higher Degrees Committee with Professor Musime there, and I see some of our students whose studies we've approved who have presented work here, which is very good. Even Professor Byamugisha is part of that committee, so we are very impressed that the work is taking place. So the approach we followed a scientific process to come up with this research agenda. So whatever is going to be presented is really grounded in scientific principles. So just briefly to go through the approach, we went through this using a number of phases that were iterative in nature. So that's why the arrows, are pointing in both directions. So we would move back and forth through the different phases. So phase 1, we had to do a comprehensive desk review of various documents, and David will elaborate on those. But we had to acquaint ourselves. Remember, we don't work at UHI. So we're an external team that were approached. So we had to go through a comprehensive review of certain key documents from the Institute. I'd like to thank the management for providing all these documents. They entrusted us with all the documents. Of course, we signed confidentiality agreements, but they gave us whatever we needed, and you see an outline of what we reviewed. But they included even some of the reports of the last scientific dissemination meeting that was held last year, as well as other annual reports. This was very important for us to establish the CVD disease profile at UHI locally, so that it informs whatever we come up with Phase 2, we had to do a scoping review of literature because we wanted to ground whatever research agenda and themes you come up with in the local context, but also having a global touch and also a touch of areas with whom we share certain social demographic profiles, the LMICs. So we had to do a scoping review of literature, looking at research priorities in CVD care, in other settings, so that we compare with what we have. And this involved both quantitative and qualitative studies that are published, but also we went ahead to look at gray literature, which is not published, wherever we could find it. And the aim of this phase was for us to get a sense of what the research priorities are in other areas that are similar to us, but also in other areas that we call high-income countries. Phase 3 involved primary data collection. We held a series of meetings, and would like to thank Judith, we thank your committee, and Dr. Sebata in absentia. We disturbed them a lot. We held meetings with the research committee, but we also designed surveys and also carried out key informant interviews. We tried as much as possible to reach everybody at the Heart Institute. But of course, as you know, in research, you can't reach everybody whom you target. But at least we got a good number that gave us power for what we wanted. We conducted key informant interviews with key stakeholders within the UHI and outside. And also we performed a SWOT analysis. And this was very important to us. And this SWOT was embedded within what we got from the survey, but also from the key interviews that we conducted. We wanted to have a sense of currently what are the strengths of the Institute in conducting research, so that those strengths can be leveraged upon. What are the opportunities out there to accelerate research so that the Institute can harness those opportunities? What are the weaknesses that are currently existing that hinder research so that they can be worked upon? And what are the threats so that we can have a plan to actually counter those threats that would threaten the conduct of research? So all these phases informed each other and would move back and forth. And the last phase involved a consensus building approach, okay? Where we would meet the research committee, disseminate preliminary findings from our steps, and then they give us feedback. We go back, we refine. As we look through more documents, we review literature, and we talk to people through interviews. So there was a back and forth movement, and also to build consensus for these research themes that would speak to the goal, the vision, and the strategic direction of the Institute. So at the end of all this, which involves even today, to present to you this, we came up with what we would call our outcome variable. The variable of interest, which is the research agenda document, which you have. You all have a summary. There is a bigger document that we have prepared. But at the end of this, we've come up with a research agenda for Uganda Heart Institute that we are disseminating to you today so that we can get some of your input before finally we submit it to the director who procured us. I remember that's what the word used. So, David, you can come and take us through some of the key people we interviewed, and then we proceed. So I hope you'll use 1 minute like I've used.
Yes, good afternoon. I'll also be brief in the interest of time. I'll mostly elaborate on what Dr. Roy has spoken about, but also appreciate everyone that put it the time to participate in this process of developing the research agenda for the UHI. Dr. Roy said we did a desk review of several documents. We got international documents from the World Health Organization, World Heart Association, World Heart Federation, the European Society of Cardiology, the American Heart Association, amongst others. We also reviewed national documents, the National Development Plan 4. We also reviewed documents from the Uganda Heart Institute. Special thanks to the research committee that coded us those documents. Prof. Byamugisa has displayed the UHI Act that has been reviewed into CAP 258. We had a look at that. We reviewed several annual performance reports from the Uganda Heart Institute, the current strategic plan. We also reviewed the approved structure of the Uganda Heart Institute, amongst others. We then conducted an online survey. I am sure most of us got the link and participated, and we appreciate your participation. We conducted several key informant interviews. The Minister of Health accorded us ample time. We appreciate that. The Commissioner on Non-Communicable Diseases and his assistant in the Ministry of Health. We appreciate the Chair Board of Directors, Dr. Magara, the Principal College of Health Sciences, the Executive Director of Mulago National Referral Hospital. We also got information from a cardiology fellow at Yale University, who is a Ugandan, and he partly informs the document that you have. We also appreciate the participation of the staff of UHI, led by the Executive Director, Dr. Magino, and the Deputy Dr. Lwabi, senior consultants, heads of departments, and all staff. We appreciate you for participating in this, the development of this document. So I'll take you through a brief pictorial of the process here. The team was received cordially by the minister, and we had a detailed discussion about the research agenda of the UHI. Notably, the minister is very interested in the UHI, and we appreciated that. The Commissioner on Non-Communicable Diseases, who is also a member of the Board of Directors, UHI, Dr. Ayo, we interacted with him as a key informant. We appreciated that. His assistant, Dr. Motonji Gerald, Assistant Commissioner on Non-Communicable Diseases, also gave us audience. The Executive Director, Dr. Omagino, and the Deputy, Dr. Peter Rwabu, we appreciate you for participating. We appreciate management for supporting the development of this research agenda. It's been very inclusive, but also particularly the research committee of UHI chaired by Dr. Sebata, as well as Dr. Namuyonga, the deputy. We appreciate you so much. This is the end of my portion. Dr. Robert, please take over. Thank you.
Thank you very much, all protocol observed. We are really standing between you and your lunch. So I think you are getting irritable. So these are part of the results. We've decided to summarize them. We've not put the statistics of the survey, but this has been informed, and from the feedback from the research committee, we developed it into thematic areas, which we think are quite inclusive. And they are really in the order of priority in the different sections. So the first one, thematic area, was the cardiovascular disease. And basically, the highest interest was hypertension. And this is not surprising because of the current problems that come from hypertension. Rheumatic heart disease, heart failure, you have this list, so I won't disturb you too much, but maybe go to the last one, the cardiovascular and kidney metabolic syndrome. Of course, you know I'm a nephrologist. But we are really going into the world where we no longer focus on single diseases because all these things relate together, and so the cardiovascular kidney metabolic syndrome puts us all together. And it's very important that as you think through these areas, you consider that. The next thematic area was behavior and community-based research. I think you've seen from the earlier morning presentations that without involving the community, you can't get anything going. In fact, most people say there's nothing for us without us. So if you want to develop anything for the community, you have to engage them, and health promotion is one way to do that. Cardiovascular disease prevention, awareness, and this is why we have a big August house here, and CVD screening in the community and also in other health facilities. All these were really outlined. The third one was nursing care in CVD. And of course, most of our respondents were nurses, but it's very important to realize, and I was very happy to see that the head of research is actually a nurse. And so sometimes we really neglect the nurses, but in this area, they got really a big theme. And they talked about education and patient advocacy, nursing interventions. We don't? Okay. Thank you. Nursing intervention, post-operative assessment, and also palliative care, as well as cardiac rehabilitation. Our fourth thematic area was cardiovascular care health financing. You know, nursing can be done without money, as we have seen this morning. And of course, we also saw the approach of the director of the Art Institute when they removed the limited sign so that they could get the money. So we know that, of course, cardiovascular health needs to move with money, but this needs to be done efficiently, effectively, and equitably. And this means that no one should be left behind. These themes kept coming up, and we should also consider that the surveillance which goes on in the community should be costed and implemented. And then health economics to make sure that whatever we do is cost effective as we develop this research agenda. Health systems, I won't belabor this because we all know that actually it's very important to have health systems that work. The way the patient comes from the community to when they reach that open heart surgery, it is very important that that pathway is made very clear, and people we interviewed made sure that that got underway. The sixth theme was on ethics and human rights and the law, and we are very happy to have Dr. Mobuke, who is an expert in this area, but people contributed a lot. These are international standards. You can't go, there's no two ways about them. So we really made sure that this was exhaustive, and in the detailed document, this was clearly explained. Of course, we know that this should have professionalism. We should also have responsible human research and good clinical practice. Then the area 7 was really pharmaceuticals and therapeutics and supplies. Because we need standardization in this area, we need to develop and participate in the development of new formulations. We shouldn't be just consumers, and then we should have drug information systems. But more importantly, the critical area here was looking at the traditional medicines. Some people thought that we should not leave these ones out, even if we are, as we deal with the hearts, and I think many people have done this, and so we should not throw them out. And then the 8th thematic area was ICT, artificial intelligence, and equipment. In this time and era, if you are not dealing with ICT and AI, you are definitely going to be left behind. I'm happy to have noted that the Heart Institute is already doing this, especially in rheumatic heart disease. So that came out, and the issue of developing devices that are going to further health care as well as health and increasing its access. I think a few people have shared about that. Then the area of diagnostics, the echo, the ECG. In fact, some people felt that probably this is being underutilized. I think I don't know the number of echoes you do per day at the Uganda Art Institute. Imagine you put that database and stored it, and actually would probably develop an app that you can just put on the heart. Oh, sorry. You could just develop an app that you could just put on the heart, and it tells you the diagnosis of those people you see. because you'd have enough information from the AI, and that's where we are going. So please store those images. Then the other part was advanced cardiovascular interventions. You see the list, but what we didn't include here is actually the critical care cardiology, which was a very important part. And now this one is the issue where we did the SWOT, and it's very important to appreciate the strength. I think that has been done well enough, but the issue that the Art Institute is established by law is very, very important, and I think it was emphasized. They can actually, they own our hearts. So that's very important, because whatever they do has a legal backing. Then the research committee, there already existed a research committee. I think you can read the rest of this. But they also had a big host of collaborators. But what we also thought was important, as you have seen here, is the vast educational capacity they have. They have undergraduates, they have postgraduates, they have consultants, they have international collaborations from Africa and outside Africa and many other countries. So these are very big strengths. And of course, they have also done several studies that have involved WHO and other big players. A few weaknesses we noted was lack of grants management unit, which is specific in most of the institutions that have taken research. Research generates a lot of money, and in order for you to be able to do that, you probably got to give it enough strength and management, because it doesn't compete with Uganda. In research, you compete with the rest of the world. And of course, the research skills, there are few individuals who are world class, but we need to have the majority engaged in this area. And then the motivation of staff. Most of the people get recognized for the clinical care they do, and most people are probably not appreciated for the research work they do. And of course, the funding for research was also limited. Then we got, I'll go into the opportunities. There's a new hospital which is coming. That's a big deal. And the Uganda Art Institute and the Ministry of Health should take advantage of that. You've seen the minister here, so there's very good political and technical will from the government. Of course, the government requires policy, and I think the executive director mentioned that. So this is a great opportunity for that. There are many research collaborations, there are favorable laws, and of course, UHI has a potential to generate its own money, because as you've seen from number one, which is their greatest strength. There are a few threats. Of course, we didn't see many research groups. Probably there was one big research group of rheumatic heart disease. The rest are quite fragmented. We need to get research groups from the nursing sections and the other sections. There's the research that has been generated has not been translated so much. And of course, members thought that they can do better translation, especially in the area of nursing and most of those patient outcomes that they see. Of course, there is low funding from government for research. And some people gave the example of the MacRIF, where Makerere University has got a big basket directly from government. And we believe that the Art Institute will also be able to do that. And more importantly, before I leave and call a professor to come back, Prof, prepare, the issue is that there is a changing landscape in the world. We all know what is happening in the world. Besides the wars, the funding has been pulled from Uganda. The Europeans, the Americans, they are all taking away the funding. So we should be able to generate research funding from within our country. Prof, please come and take on the last slide.
I have noted that lunch vouchers are already been distributed, so to make sure we move carefully. Thank you very much. Now with all this, and we have tried to summarize it, we have a number of recommendations, and these involve, we feel, the team came up with a big feeling that there should be a directorate of research with adequate staffing. That means it has a number of people, epidemiologists, you have in other words, should be diversified. Health systems, policy analysts, behavioral scientists. And at the start, when this is forming, these people should have multiple skills. so that somebody can be able to move, for example, into IT and be able to address a number of these. So it is a strong one, especially as you move to the new home. This directorate should be formed, and initially it can start small, but you see it could align all this research that is being done and also come in how to attract other grants. Now then, a grants management unit. This is a necessity. It should be established under the Directorate of Research to support researchers in finding opportunities, because in a number of institutions, finding opportunities are usually saturated. And like here, your Heart Institute is even unique. You'll find there somewhere you are the only people who can actually apply, and you would be able to get this. Research and Ethics Committee, you know, it's a big strength and can be strengthened further by the acquisition of a federal-wide assurance number, FWA. And basically what it does is ensuring that there is a lot of compliance with documentation, especially as far as human subjects protection is concerned. And some funders at times want this, and it can increase the chances of getting grants. Some of these we are mentioning already in some of our institutions that do research. Engagement with global research networks is highly encouraged, and there is evidence already there, and that can continue. But we would also want it to be two-way, that if, for example, they don't come, get information and want to use it without involving our people. So and there should also be staff and student exchange. It can be widened, can be strengthened. Research infrastructure, establishing multidisciplinary research teams. My colleague has just talked about this, Robert. But ICT, artificial intelligence, because many things are moving in this direction. Efforts should be made to computerize all the data by considering an integrated cardiovascular management information system, ICMIS. This is an interesting acronym. And also in line with the Ministry of Health, urging every institution to make sure that everything is integrated. We noted there are areas where some systems are already developed, like for rheumatic heart disease. But as you can see, that with time, rheumatic heart disease may even be eliminated. So we want it for all the diseases, so that it is very easy for us to, like you just click buttons and you can be able to analyze and get data regarding all the conditions that are managed from the Heart Institute. And you've seen the very busy clinics. All that is data. All that is opportunity for research. Conduct cardiovascular research that specifically targets regional needs in the country, since they have different demographic profiles. This comes in that, for example, the cardiovascular disease patterns in Eastern Uganda may be different from those in Western Nile and those from Western Uganda. So doing research that is just cross-cutting may not be enough in terms of profiling people, treating them. When you look at the BMIs, there are many factors you can analyze there. And this came from a number of people we interacted with. Research skills training for staff should be done in areas such as, study design, is data collection. Basically what is needed to conduct research. This can be strengthened for all the members at the Institute. Manuscript writing, science communication, you can see some of it coming here, and it's quite a lot that you have. It's just really building on it and reorganizing. Strengthening collaboration with in-country research institutions. We have mentioned universities. Good enough, we see members of the academia. Some of them are already here. I see Professor Musime there, Mayor, they are all there. And others who are interested and have not appeared here that can really actively participate. MACRIF is Makerere University Research and Innovation Fund. The government has been giving it some monies, but it's not only for Makerere to apply. For example, Uganda Heart Institute can work with somebody who is in Makerere University and be able to tap these funds, and it is highly encouraged. So these are areas that can really be tapped into, and I'm sure eventually, of course, government will eventually put more funds in here. Utilization of available data to conduct basic operations research and routine audits, because at times even just analyzing the prevalence of certain conditions can be done by people. And we would also, you see, like some of our surgeons, you've seen surgeons, people are doing a lot of research, interventional and non-interventional. That should not stop there, because when you don't publish, you can perish. And yet, for example, you have a lot of skills that people could learn from. So this research becomes very important. Promoting interdisciplinary research. Research teams that are interprofessional in nature should be established at UHI. Again, my colleague has talked about this, but what we are looking at is you have doctors, you have nurses, you have social scientists, so that even no groups are left out, and also including other disciplines. There should be a comprehensive cardiovascular disease registry that encompasses a number of cardiovascular disease conditions. You've had things like cancer registry, but like here, because you are basically the group now that is on to handle all this. Everybody is looking at Uganda Heart Institute. The region is looking at Uganda Heart Institute. So having that database will be very useful, not only for Uganda, but as we've said, for the region and internationally. You should continue to participate in global NCD surveillance activities. There is one important one which is called STEPS, usually run by World Health Organization. This is highly recommendable. And there are other opportunities which will come where the Uganda Heart Institute should actively participate and move forward. So members, that's a summary of some of the main recommendations. We want to acknowledge everyone that has participated in this. Even when I do eyeballing, I see a number of people who actively contributed to the ideas that we are currently sharing. So we appreciate each one of you and different capacities. Starting, of course, Uganda Heart Institute staff, from the director and your team. It was very, of course, we realized that, you know, almost everybody who handles heart disease is in the Uganda Heart Institute. So it is good that you looked outside, that you could get some people to now look on the inside. Minister of Health, Makerere University, World Health Organization, UNICEF, National Council for Science and Technology, Makerere University Lang Institute. There is another one here, Soroti University. Yes, Professor Ikoja. Thank you so much. And Dr. Mukasa, who is here. We've been working with him, one of your staff. That's how, we haven't put it because you are here. We're already with it, this logo. And the National Research Organization, there is also Uganda National Research Organization, UNRO, which has also actively contributed to this. So this does not mean that the ones shown here are the only ones who contributed. There are others, but we just picked out some few. There are many source documents, my colleagues have mentioned them, and again, these are just put here basically to demonstrate, but even there was also an NCD surveillance report that was done ranging from 1990 to 2020. We also had a look at that. So, before I make the big thank you, members, thank you very much. Research drives development. Research drives development in some areas. Before you do anything, you have to do research. So if you have come here for a research dissemination, it means you are interested in development. So let us continue to perform, conduct research, and develop together. Thank you.
Wow, thank you so much, Professor Joseph Abiamugisha. Ladies and gentlemen, please, a big round of applause, please. That was too slow. This work you're doing is quite colossal. It's no mean undertaking. And I think most of us were just smiling when you were presenting and your team. Thank you so much. And as people go for lunch, you give them a mouthful. So they'll chew over this over lunch. And when we come back for the second session, we shall start off where you left off, and we'll have interaction with you and your team, your Q&A. Our lunch is ready, so without wasting time, we'll have a short prayer by me, then we shall move up to the next floor for lunch. Oh God, we thank you for this day. We thank you for the work that has been done this morning. We pray that as you go for lunch, may you bless the food, that you give us strength to do your will. Bless Christ our Lord. Amen. Have a lovely lunch. We'll have 30 minutes for lunch, and we'll be here let's be here by 3 p.m.
cardiovascular risk at baseline. This is a sub-study of a SATRAC study. SATRAC study is a cancer cohort of anthracycline-treated patient. We presented the data of the main study last year in the research dissemination day. So in the main cohort, we have total 207 patients, and patient who meet the criteria was selected. That is a patient who had breast cancer, age between 18 and 49, and the patient has baseline and blood sample, and also after post chemotherapy blood sample available. And the patient who has pre-existing cardiovascular risk has been excluded, including hypertension, diabetes, obesity, HIV infection, CKD, and chest radiation. So finally, 34 patients has been enrolled in this sub-study. And the demographic and clinical data were extracted from the main pool. Their serum samples were collected at the baseline, and also post-chemotherapy were analyzed for the lipoprotein and subfraction. So this is the lipoprotein system we used for the blood analysis. For lipoprotein subtraction, we use the method of gel electrophoresis. So this shows you the scan of the tube of 12 individual patients. From up to down is in a descending order of their size. The upper one, the top one is VLDL, and then the lowest one is HDL. In between, we have IDL and LDL. The analysis result was automatically demonstrated by the machine in this graph. This is showing the result of one patient. And the quantification of the lipoprotein subfraction is calculated by the relatively air under the curve. And pattern A is defined by the mean particle diameter more than 26.5 nanometer, and pattern B is less than 26.5. This is the result of lipoprotein, and it shows significant increase of total cholesterol, and also triglyceride and the LDL level after chemotherapy. And also the apolipoprotein B also significantly increased after chemotherapy. So this table is very crowded, but I want to show you some important message from this table. First, the patient weight, BMI, and BP didn't show any changes after chemotherapy. And for lipoprotein subfraction, only VLDL shows significant rise after chemotherapy. However, the most important data is at the end of this at the bottom of this table is showing the significant reduction of average of LDL particle size, and also for LDL subfraction pattern before chemotherapy, they are all pattern A, and after chemotherapy, there are 5 of them have shifted to pattern B, which is associated with higher cardiovascular risk. Here showing the example of one patient's result. The left is the before chemotherapy, and the right is after chemotherapy. It's showing you how the pattern was shifted from pattern A to pattern B. This is the Poisson correlation test showing the moderate correlation of anthracycline dose and LDL particle size reduction. And also, simple linear regression also showed the anthracycline dose increase was associated with the mean LDL particle size reduction. So this pilot study demonstrated a significant increase in non-HDL and also increase in VLDL subtraction, showing a reduction in mean LDL particle size and a shift in the LDL subtraction pattern following the completion of anthracycline-based chemotherapy. Cumulative dose of anthracycline is associated with the degree of LDL particle size reduction. Anthracycline therapy might change patients' cardiovascular risk. We noticed a number of limitations of this study. However, this is the first study to investigate the change of lipoprotein subfraction on anthracycline-treated patients. So, what's the implication of the result of this study? Should we start testing or screening people's lipid profile after the chemotherapy? Or do we know whether this lipid change is reversible or irreversible? So obviously, if we want to know the answer, we need better design and powered research in the future. Thank you. We thank you also for all the team members from their support and our founders. Thank you for listening.
Thank you, Dr. Zhang, for that insightful abstract presentation. These are quite interesting findings. This is novel, it's one of a kind. Relationships, especially, she's been doing a study where she looks at the effects of chemotherapy and LV dysfunction, and further sub-analysis have given us these interesting findings. Our second presenter will be Dr. Nakagai Doreen. Yes, of which she's an adult cardiologist, yes, with a special interest in rheumatic heart disease. She's among the teams that are pioneering quite interesting questions that are focused on tackling one of our biggest challenges in cardiovascular diseases in Uganda. Dr. Doreen, the floor is yours. You're welcome.
Thank you so much, Elijah, for that kind introduction. I'll start away with an abstract titled Evaluation of a Training Program for Rheumatic Heart Disease Screening Integrated into the Public Health System in Uganda. I have no disclosures. As a background, echocardiographic screening, as presented earlier, is highly recommended approach for rheumatic heart disease care. The World Health Organization recently, that is last year, brought out new guidelines for screening in high-risk populations, but scaling services is still complex. Task shifting for rheumatic heart disease screening has been proposed since 2015 as an alternative approach, but there are no standardized training programs that exist to guide this approach. In 2023, the DUNU program, many of us have heard about it, but this is a program that was deployed by UHI and the Ministry of Health into the public health system of northern Uganda, in 2 districts in northern Uganda, basically targeting primary health care providers to pilot integration of rheumatic heart disease screening into Uganda's public health system. These providers went through a 3-step training curriculum that involved pre-training with online modules, and then in-person training with didactics and hands-on for a week. And following successful completion, they were offered conditional certification to integrate screening in the health centers, in the community outreaches, and in the schools. So after that, they went into that 3rd stage where they are integrating screening, and that was supported by expert reviewers who reviewed all the images that they were acquiring and provided real-time feedback on image quality as well as diagnostic accuracy. So providers who screened over 100 participants and achieved 90% accuracy with good diagnostic image quality received final certification. So this particular study aimed to evaluate this novel training program to inform the designing and refinement of a standardized curriculum for RHD screening. So the methods we used, we evaluated the DUNU program 15 months into its implementation, guided by the logic model, which is known for evaluation of implementation programs. We used programmatic data to describe the resources, activities, outputs, and outcome of the program, of the training program specifically. So among resources we had, they were classified into two, material resources and human resource, and these included handheld echoes, tablets, training materials, cloud-based image transfer systems, and human resource really included UHI trainers, remote experts who provided review of echoes, and Ministry of Health supporters with the trainees who actually participated in screening of participants. Activities, we had 4 main activities. We had initial training, which was really intense, and then healthcare work remediation for those who failed to achieve final certification, but consistently continued to screen in the community. And then participation in the didactic and hands-on scanning by the trainees, as well as remote expert review. Cumulatively, this took us over 5,000 hours, and the most activity that took a lot of time was health worker remediation and support. We realized there was a lot of human resource needed to provide support at the health centers and training. So when we costed both the resources and activities, cumulatively, this costed over $78,000 US. So for training outputs, we trained in 10 public health facilities, 61 trainees completed training. Of these, 95% were conditionally certified after the in-person training, and only 58.9 of these are screened consistently. And over time, we realized that we had to stop some trainees who actually failed to consistently screen at these, in the community. So for expert review, we had over 10,000 echoes performed by these providers, and over 9,000 were uploaded for review, and each expert reviewed at least 1,000 echoes. The main technical flaws here were really optimization of image acquisition, specifically color box positioning and appropriate image depth, as well as recognition of RHD positive scans was also a challenge. So 29 participants required remediation. So general outcomes for the training outcome, 17 out of 58, that was 29%, received final certification, were able to achieve final certification, and the median duration to final certification was 6.9 months, and only 4 healthcare providers did not require remediation. So remediation was really intense for that team. The screening outcomes, we had 5.3 screening positives, but what was so amazing was that these trainees acquired optimal images even in the first week of training. They were able to acquire diagnostic images, and so 97% of all images were of good quality. Overall sensitivity, that is when you include all the trainees that completed conditional certification, was low. It was 59%. But for those that were finally certified, their sensitivity was way above 90%, and specificity 96%. So what did we learn from this? We learned that training for RHD within an existing public health system is feasible but resource intensive, and seeing that healthcare workers demonstrated technical competence in image acquisition within the first week and maintained this high quality image acquisition until the screening period was very key. But the gaps were really in screening accuracy, which was low, and during the conditional certification period. So the implications from this evaluation was the fact that we need to intensify retraining strategies and focus on really on identifying positive cases and improve RHD sensitivity. But also we need decreased reliance on human resource. We think of alternatives like automated intelligence tools that can support image interpretation, can provide automated booster training and continuous education. And currently we are studying large language models that are helping provide boosters for trainees without human resource being available on site. And the other issue we noticed is that we need early identification of adopters, good adopters, and high performers, because as you see, while we trained 58, more than 40% of those did not consistently screen at the health centers. And so some of the work we are doing is to identify those factors that can really help us identify providers that can implement the strategies as trained. So in conclusion, continued learnings from this large-scale initiative will be instrumental in refining the training model with a focus on maximizing its effectiveness and reducing the burden on human resources. Thank you so much.
Thank you, Dr. Doreen, for the wonderful presentation. Please join me to welcome our next presenter, Dr. Isaac Sinabria. Dr. Isaac will be presenting hypertension landscape in Uganda, evidence, guidelines, and implementation. Dr. Isaac is an adult cardiologist at the Uganda Heart Institute, and he's our head of the outpatient department of the Uganda Heart Institute, and is among the young and budding cardiologists that were presented in the morning. You are welcome, Dr. Isaac, and it happens that you'll be taking us in 2 presentations. So after this, you continue into the second one. Most welcome.
Thank you so much, Dr. Muhozi. Good afternoon, everyone. All protocol observed. Happy to be here and share some work with you. It's going to come, okay. Yeah, so I'm going to, in the next few minutes, I want to talk about hypertension, the landscape that we are observing currently in the country. And this work is being presented on behalf of a bigger team, like you can see there. So we know that hypertension actually forms the biggest bulk of the NCD in this country, approximating almost a third of our adult population. They are being burdened by this. And consequently, this is leading to the rise in stroke, kidney disease and heart disease. And we know if we are to win this battle, we need to effectively tackle all the levels, what we call the cascade of care. How much are we screening, diagnosing, treating, and therefore controlling? This is just an extract to show you where we've moved and where we are. If you look at 2016, good thing these things are color-coded. You see there is some scattered reds in the country, mainly around the central. But as you go 2017, 2018, and then 2019, 2020, and 2021, it's becoming more and more scary. More reds, meaning that the burden of hypertension is becoming a bigger problem. This is work that was done by Professor Bruce and actually Robert Kalyesula here, where they looked at geographical differences in the prevalence of hypertension in Uganda. The results are from that epidemiological study. And we see that actually prevalence in some areas, it reached higher than 30%. The burden is big, but we need to be ready to tackle this. And of course, the central region is getting the bigger share. For us to manage these conditions, because hypertension, some work we did that shows that 60% of the bulk of non-communicable diseases are in the community. So for us to actually manage it very well, we need not only to concentrate at the tertiary levels, because just imagine 30% of adult population, that's over 8 million Ugandans having hypertension. UHI, we don't have enough space or compound space to get them, but we need to manage them at various levels. So this UCG, it had last been revised in 2016, and guidelines are basis to create a demand and to point us to how we can actually manage various conditions. But of course, let me just highlight the hypertension. So when you go into the old ECG, you will see that at Health Center 3, yes, they were mandated to manage hypertension, but with what? So we see Aprinox, and then if that's not managed, you send to stage 2 calcium channel blockers, the famous nifedipine. But we are aware that nifedipine causes leg edema, palpitation, headaches, and this can affect adherence. And when you go to Health Center 4s, they had some captopril and enalapril. Then when you go to the hospital, H's hospital, then they had some losartan, and then as you go higher, then you will be privileged to find beta molecules. But the question is, these antihypertensives, of course we have the classes, and from the old ECG, at what level were we legally utilizing them? We found that drugs, that old molecules, thank God they worked then, but now that you have beta molecules, we needed a guideline that can help us manage our population better. If you have 8 million Ugandans, and we see many of them can be managed in the community where they stay. So that is Health Center 3, Health Center 4. So we needed to see how do we strike a balance between access, costs, side effect profile, effectiveness, and then the commonly available, of course, we've gone through them. And we are aware there are frequent stockouts. So even the atenolol and the nifedipine that was causing some side effects was running out regularly. So just to show you the evidence and what resulted into the change into the guidelines, most of the work I'm going to report has been done in the HIV settings. And it's because until a few weeks ago, there have been centers of excellence, and they document, they have the data. So still, Dr. Kalyesula and team, they did a retrospective study in the MJAB. I happen to have practiced in that space in my earlier years. But they demonstrated that between 2009 and 2013, there was a doubling of hypertension in that patient population, which, you remember the figures I showed you, becoming more red. So we have more evidence that will show us here. But they found that only 23% actually were receiving optimal treatment. During my master's, I did some work, and later on, after 5 years, I needed to look at the transition, how these factors actually change. And I won't go through the details, but I will share these slides. Still, in 2012, and then 2012 plus 5, 2017, in that cohort I was following, I saw actually a tripling of the burden of hypertension and all the other risk factors also increasing. When you look at the search study, Professor Kamia and the RDRC team, for them they've done community screening in the western part of the country. They screen many people for HIV and hypertension. They realized that linkage to care was actually a problem. They gave incentives to facilitate this linkage. But then at baseline, they found that control of hypertension was only 15%. But when they linked with the incentives, it went up to 46%. Why I'm bringing this is the biggest success that you can measure and gives you assurance is when you can actually have BP controlled. If it's not controlled, you've not done anything. One of my students, he was in Tororo, and he was wondering what's going on, the cascade that I've been talking about, screening, management, and that kind of stuff. It was very low in those settings. But the UCG, the Uganda Consolidated Guidelines for Prevention of Treatment for HIV, in 2020, because of the rising prevalence of hypertension, they talked about integrating care. And I think that's why we are seeing a lot of success in that area. I'll skip this as well. It also emphasizes integrated care. And now that funding has changed, the health facilities have to really integrate to be effective in managing these patients. So with that in mind, we set out to study, can we in this sub-Saharan Africa and Uganda be able to design and work with evidence to design protocols that can actually demonstrate that we can care for our patients. So the WHO Art strategy that looks at health, lifestyle, evidence-based protocols, access to medicines, and all that. But before we carved that, Uganda participated in one of the trials, what we call the CRORI trials. And it demonstrated that in blacks or in Africans, amlodipine with either a thiazide or an SCE was effective in controlling. So amlodipine formed the backbone of our care. So still at MJAB, we said, okay, let's see, what are they doing at baseline? We found that diagnosis was 24%, initiation of treatment was at 1%, and this, of course, couldn't give you a lot of results. So applying that protocol that had the backbone of amlodipine, and then we use what they call the Novartis Access, where we're spending $1.50, about $5,000 for a package of 1 month. It was cheap. So a step-by-step algorithm to manage hypertension, we're able to see that these patients can actually get controlled. And in a span of 6 months, the curves had changed. So we had 100% diagnosed, 100% started on medication, 98% retained, monitoring happening in all of them, and 75% control in 6 months, meaning that it works, the molecule was cheap, and less side effects, because we know amlodipine is not as bad as nifedipine. So this subsequently led to discussions around, we need to revise the UCG. Of course, my team and group, we have a long-term plan of controlling hypertension. I'm a heart failure specialist, and I know the biggest culprit is hypertension. So it's within interest that I lessen my workload by controlling the biggest thing that causes a problem. So we revised the UCG with several people, and we've set amlodipine as the first line, ARBs as the second line, and with ARB, we're talking about either losartan, telmisartan, and valsartan, depending on what can be accessed, and then up-titrate the doses. And then you can go on to bringing on board the thiazide, because the evidence has been there, and we've proven that that works. The beta blockers can come in later on, and then if that doesn't work, we can refer to the higher centers. But can we manage the bulk of our patients at the lower centers? So this has led to the contribution of the revision. And like I said, until a few weeks ago, there was so much that happened in the HIV space. But the lessons that we are learning from that, we can actually export them to the general population. Their guidelines have all been revised, actually, and they are being implemented. Training of people across the country in these guidelines. The UCG, of course, it's now bulky, but if you go in there, there is actually step-by-step on how we can manage. The greatest tool that actually, for us, as I conclude, is The revision of the NCD guidelines alongside the essential medicines list gives us a legal mandate, because you remember where I started, nifedipine at Health Center 3. Amlodipine, by the way, was tagged for regional referral hospitals, but now there's a team we're doing work in Kazo and Luwero. Health Center 3s are the bulk of what we're doing. They found 58% availability of amlodipine. For me, it was a great check that actually people are starting to implement and making these molecules available. So this is going to streamline referrals and to reduce unnecessary out-of-pocket expenditures, decongesting tertiary centers, such that we are doing what we've really been trained to do, and the lower cadres can actually do a great job in controlling and preventing complications. Thank you. Sorry, one of my staff traveled, so she delegated me to present this next piece of work that I hope I can run through very quickly. I hope I'm audible. Great. Yeah, so the next presentation is around building mid-level provider capacity for diagnosis and surgical management of cardiac conditions through training, mentorship, and case detection under the PEN+. Yeah, so still I'm presenting on behalf of the team, and here Dan is not in the house, but Judith is here. So as a word of background, decentralization of care for NCDs, including complex cardiovascular conditions, is very critical because we know at the tertiary centers, access is a challenge. I mean, 48 million Ugandans. I don't know how many years it will take us to see all the 48 million Ugandans in the tertiary center. So for us, it's inevitable that we have to shed off some work to mid-level and other places so that they can be able to share this burden. So the PEN+ initiative in Uganda seeks to enhance the general hospital capability for long-term management of adverse cardiac conditions through targeted training for these mid-level providers. So briefly about PEN+, you're free to Google it, check it out, but this is a program, a model of integrated health service delivery that seeks to manage severe or advanced chronic NCDs, but at a mid-level, because our earlier work demonstrated that 60% of these conditions actually are in the community. So by the time they jump all the levels to reach us, they will be dead or they will have irreversible complications. So we sought to build a model that can actually be able to see this. And it's building on through the WHO PEN, which was previously looking at diabetes, hypertension, asthma, COPD, and then cancers. So those big four. But we realize that actually, if you look at those big four, they don't actually even occupy a sizable proportion of the entire NCDs. There are those previously not categorized, for example, sickle cell, type 1 diabetes, rheumatic heart disease, congenital. They're not among, because previous was hypertension strictly. But we saw that outside that, there's quite a lot that we're missing. So training these mid-level providers to be able to do quite a lot. So this work has been going on for some time. We are in Kumi and Nakaseke, and so 2 implementation sites. Over 30 health workers have been trained. Over 2,000 patients are benefiting across the different disease conditions. And at Tutul, we're working with a funder who doesn't build. But when they visited at Tutul and they saw people were being seen under a tree, they said, we must get them a structure. So they have a beautiful structure. So we implemented a structured echocardiography training curriculum in these 2 sites. Thanks to the presenter before me, provided a detail. So I won't bore you with a lot of that, but structured training people and be able to build their competence. And we have experts who sees and regular mentorship. And then they have logs that they do some of these cases. They are sent. Initially, we're using WhatsApp, but now we have a platform through Harvard where we can actually relay images and we can be able to support them. So training emphasizes the integration of clinical assessment and then the echo. We're not training technicians, right? We want them to actually think in an integrated way. This child who is failing to thrive, repeated chest infection, when I auscultate and I hear a mama, by the time I put that probe, already I've thought through many things and we'll be able to pull these. And we get quarterly refreshers where Judith goes and supports these people, and patients are sent to the institute actually for screening, and then they are planned for intervention. So key successes, the clinics run in a tutu because the bulk of the patients are there. On Nakaseke, it's Thursday and Friday. Diagnostics, we provided portable echo that they use. And then for other disease conditions, there's spirometry, there's a gazelle for sickle cell. It's the core, so it's really emphasized, and we're happy that these are sites where learning is possible. Data, through the research agenda, data is key. Data is capture and quality, support for patients, and patient support, and then the referral system. So the breakdown, we've done about 273 echoes at that mid-level, and to our surprise, we went looking for RHD and others, but RHD is 5.1%, but congenital is 12.5%. Uganda is a young population, and there's a lot of undiagnosed congenital heart diseases. So what a great opportunity that we can actually pick these early, and then intervention is done. Majority of these are PDAs, but we've also seen a lot of complex things. The beauty in the training, you are shown what normal looks like. So anything that's contrary to what's normal, you flag it. Normal, it doesn't look normal. If you can make sense out of it, good. They write their notes. And if you can't make sense out of it, there is another layer that can actually help you, take you through. So there is the truncus repair that actually was picked. Initially, they just saw the VSD, but there is a keen eye. We celebrate Judith. She's good to this program, actually, because she's deliberate and she pays attention to detail. And as a result, many people have learned, but she's been able to pick quite a number of these things and has advocated for them to be worked on. So between both sites, out of the 34 congenital heart conditions, which forms the bulk of what we see, 11 of them actually have had interventions done. 8 surgeries have been conducted at the for patients from Atutul, and that's the breakdown. And then from Nakaseke, I think the third was last week. Yeah, 2 weeks ago. One of them had catheterization and then the defect repair. So we support, we lobby for resources, but I want to acknowledge actually UHI because most of the PDAs were supported by the UHI. They were identified, and then UHI in the other financial year, they were able to actually work on them free of charge to the program. Yeah, so UHI paid, and for that we are so grateful. So in conclusion, the Pen Plus initiative, the integrated approach, comprises of the on-site training, continuous mentorship, active case detection, and coordinated surgical referral. This has substantially improved the mid-level provider capacity to diagnose and manage complex cardiac conditions. So these findings demonstrate that it's feasible. We can, in the lower centers, actually be able to pick these things and channel them to where they can actually get help. So this model, we are part of 11 countries that are doing this. And I stand here, not because I'm the lead, but I'm not biased, but the truth is Uganda has done so well. Because in other areas, they've diagnosed, and now they are praying, where can we send? But we have UHI that's ready to actually receive these patients and work on them. For that, we are so grateful. So I acknowledge all the players in this. Many people have contributed. MOH, this is an assignment handed over to us through the MOH and the funder of this and all these hospitals where we do our work. Thank you so much.
Thank you, Dr. Isaac. At least you have acknowledged the surgical team of the great work they are doing, and like Dr. Ariku, he said we still have a lot to do for the TGS. Here there is some work and some acknowledgement. Thank you. Ladies and gentlemen, we are going to first invite the research agenda team, Professor Byamgishan team, to come and we do the Q&As, and then after that we shall invite Dr. Sinabria and Dr. Zhang and Dr. Doreen for their Q&As. Professor Byamgishan, you most welcome.
Thank you, Doctor, for the presentation. I would like to know, you have talked about hypertension. You notice
So we are taking questions for the first presentation before we went for lunch. Research agenda, we'll take some questions from them, like 4 to 6. So
good afternoon, everyone. I'm just inquiring, is the Uganda Heart Institute data available to the public in case someone is interested in any topic?
Thank you so much. Good afternoon, everyone. My name is Barbara Okiror from the Nurses Council. I'd like to thank the Uganda Health Institute for this session. It has been very informative, but also it has been encouraging that going forward we'll have more cases handled in Uganda rather than flying our patients abroad, since we have specialists here. About the research agenda, I'm very impressed with the research agenda. And one of the things that has really come out is the involvement of nursing care. In the nursing profession, we have very few research agendas. And as council, we are trying to see that we transit nurses from being technical to professionals where they can do research and specialize in the nursing profession. So my concern would be, as nursing care is one of your research areas, are there strategies to encourage nurses to do research in clinical practice? The whole day today, I haven't seen a nurse presenting. Is it that we don't have research areas in nursing? Is it that they don't have a contribution to, and there are problems to be fixed? Is there a way we are trying to actually nurses do research which they are able to do? Yeah, and to inform we want to see innovations in healthcare, in the nursing care as well.
There is a nursing session coming in the program. If you revise, the next session will be for nurses and the nursing researchers. Thank you.
Thank you so much. I'll be very excited to listen in. I overheard that this is just a comment that the Uganda Health Institute, takes up the doctors and trains them. Also train super specialist nurses. Do you work at that hand in hand, or you have people of a lower cadre? I think it would be an investment for both professions. Thank you.
Dr. Ariaka, you will bring the microphone to Dr. Magino. He will answer that.
Request to see the face of the person from the council. Where? Nursing Council. Please come on this desk, because that is where you belong. 2, the biggest cohort. The Heart Institute is the first one to recognize a bachelor of nursing in the country. And the Heart Institute was the first one to say the entry point for nurses is a bachelor's. Anybody with a diploma was given 3 years to upgrade and was given money. Next is we have the nursing fellowship training program. Right now, on the fellows training, the biggest number is nurses. The Heart Institute took, in fact, at a certain time, I hired 2 flats in India for training specifically nurses. The boys one side, the girls one side. But the biggest obstacle to the development of cardiac and super specialized care is the nursing council. I want you to come here because I have a letter where we actually asked the nursing council to take on, to accredit the nursing council such that, the fellowship training program such that super specialized cardiac care is officially recognized and people can get jobs. The nursing council wrote back that that is not their job. It was such a big disappointment. So I wrote back to the minister. If she had the time, she would have vented her But the issue is, right now, that training is going on with or without the nursing council. We have foreign students. The last batch, 7 applicants from Botswana, we had to put them aside because we are still battling with the nursing council. The message to carry from this meeting is that we are going back to Parliament to remove the mandate of the nursing council to handle or to accredit the nursing training. We have been working with the medical and dental practitioners, and we have pulled through all of that. Nursing council was referring to us to the national, to the higher, is it national higher education. We engaged, that time it was Professor Opuda who was the chairman, and he wrote point blank that for them, they are in charge of academic programs, that is universities. Here, it is clinical, and that is in the domain of the regulatory councils. We are so annoyed, we are so disappointed, we are so disgusted with the nursing council. That is the message you should carry. Thank you very much. Don't answer anything.
Thank you, Director, for that message. I think he's very clear. He's not happy with the council. Hopefully, things will improve in the future.
Dr. Liaka, there is a question there. We can take it as the last question.
That one scared me a bit, but I'll have to go. Yeah, Moses from UNHCO.
Pays the bills. So that's a very good input. I think we'll include that. Then knowledge translation into advocacy. I think I'll leave that for you, Prof.
So the other aspect and among the stakeholders, I think this was mentioned. We are considering the number 4 here, which is about translating and commercializing research discoveries for societal impact. So the society is not totally left out, but maybe it can be emphasized and comes out much more clearly in terms of the presenter has indicated that. So the role of organizations can't be ignored because you can see that the hypertension is continuing to become a critical issue. And there are some areas which the concerned authorities may not take up easily, be expensive. When you look at that, we called it monitoring, learning, and evaluation. Because the term has been updated, members, from just monitoring and evaluation to monitoring learning and evaluation, so that you monitor, you learn, you evaluate, you keep learning and making things better. So it is included in the bigger document. And there is somebody who talked about MOU and every quarter. It looks like that's for the institution and Uganda Heart Institute, so that they can work together better. I hope we understood that quite well. Sure, nobody would come in the way of stopping the institution, because one of the points we have highlighted strongly is that institutions need to work closely together. Actually, if we are to develop, we have to collaborate as institutions, because we are serving one population. You see, we are looking at people who are living in Uganda. That's the population we are serving, and others who come from outside. So for us to serve them better, we need to collaborate. The energies need to be synergized, and then we can really get better results. And you've heard us even expressing it. For example, Uganda Heart Institute working with Makerere University. They are already working together, yes, but this can even be made bigger in terms of grant applications. If you are in Uganda Heart Institute, don't hesitate to collaborate. I see Professor Victor Musime there, pediatrician. Write with him a grant, and the grants can help to bring in funds. There was something about implementation framework and the financing. We have a section on financing, because we realize that you can't just write a research agenda without talking about possibilities of funding. Funding, one of them will be Government of Uganda, which Uganda Heart Institute gets funds from the government. That's one possible source. And the point here is that they have to keep advocating for more, because if some institutions are getting funds for research, Uganda Heart Institute you've seen that there is a lot of advocacy that can be done. That's one. Collaborations with other institutions, so that, again, funds, if they are obtained from MACRIF, they can help the Heart Institute to implement the research agenda. Grant applications. We have emphasized the issue of the grants management unit, Directorate of Research. Grants can bring in money. You should realize that in Uganda, for example, there are institutions which are just surviving on grants. It's a big institution. I don't have to mention some of them. Meaning that actually, if you tap to this resource, you can be able to bring funds. The other one is IGF, the internally generated funds. The Uganda Heart Institute actually generates some funds. I'm told this could be enhanced, there could be more, and some part of this can be put to research, because the research can improve service delivery. So all these are different avenues, and of course partners in development, and you have demonstrated some of them who are already like working up country and other areas. These can also support. So there are several sources of funding, and they need to be tapped into more, and you can be able to implement this research agenda and conduct more research. Members, we are not going to survive very well unless we enhance the amount of research that we can conduct, not only at the UHI, but in the whole country. I hope. Team here, Robert Kadiesubula, Loy Mubuke, David Mukasa, Xavier Savagasani, and there are two people at the back, Caroline and Jacqueline. And members, we thank you again. We would like that the ideas we have discussed are not only here, but also we can bring them to fruition in terms of implementation and see the results for the betterment always of the patient, or whatever is always for making the patient do better, and where possible, prevent the patient or the person from getting the diseases. Thank you.
Thank you very much. Let's invite Dr. Sinabia, Dr. Zhang, and Dr. Nakagai, and my co-chair. Come take your seats for the Q&As for the adult cardiology session. Come and I'll hand over to you. We shall take like 3 to 4 questions. Dr. Isaac, as you settle in, my question with Pen Plus work, RHD is among the challenging diseases to screen, and with the heavy disease burden in Uganda of the RHD cases, we have screened and we have got the data as a high-level manager at the Institute. What would be your borrowed experience in the sense of pen plus to see how to enable those initiatives to tackle the surgical burden or the now solutions for the already screened patients?
Thank you very much. My name is Florence. I would like to ask Dr. Isaac about hypertension. You talked about the new drugs that treat well hypertension. You find that in those health centers low down, they still use Aprinox and nifedipine. So is it, how is this research going to help those people down there to avail those good drugs? Because by the time they come to hospitals, big hospitals, they already have damage. Like they have DCMP, they have renal injuries, they have stroke. So how is this research going to help out? Thank you very much.
Yes, good afternoon. My question is also for Dr. Isaac. On hypertension, there's a point which Dr. Kalisupula mentioned about the NCDs and how they go together. So I feel like the more we keep on maybe separating hypertension on its own, and then you have its framework, then maybe for diabetes or maybe for kidney, I feel like we shall be losing that holistic care. So what do you think about that?
We see a lot of interest in hypertension questions. We have two more presenters who shall ask a few of them. Question one to Dr. Nakagai, Doreen. We're wondering the sensitivity of screening. It was clearly explained probably, the user training, but if we could get 59 out of, well monitored, well funded, we're wondering the impact of rolling this out, because RHD is really a disease burdened by finances. What would this mean to, a large scale rollout? And then a question for, yes, one more question from the, okay. Then for Dr. Zhang, yes, yeah. So
is that for Dr. Zhang?
Thank you. This question is for both Dr. Dori Nakagai and Dr. Senabulia Isaac. There's a lot of intersection between what you say about Pen Plus and Aduno program in Kitgum district. Is there a plan for you both to work together in future? Could you talk a bit about that? Thanks.
All right, thank you so much for the great presentations. My name is Anxious Niwaha, and I'm representing Professor Moffat Nyirenda from the MRC unit. I have a question for Dr. Zhang. In your initial hypothesis, you hinted on both HDL, non-HDL, and I thought that by the end of your talk, you could sort of tie your results of the sub-classifications of LDL back to your initial hypothesis to tell us what could be driving those sub-classifications. But also a question for Isaac is, beyond the MJAP clinics, for the packages you've implemented, is there hope that these packages will be sustainable with the current funding landscapes? Thank you so much.
Okay. Mine is a quick one. Roy Muwoke is my name. It goes to Doreen. Thank you for the presentation. But I would like to hear what concrete recommendation do you make with this training intervention? Should we continue with it, or it does not work? First of all, it looks like it's very expensive, and the outcome of your trainees from your presentation seem not to be that so good. So should we roll it out? What concrete recommendation would you make to the minister, for example? Should we continue with this intervention? And with the coming of AI, which is taking up most of these things, do we have to invest in such a training? Thank you.
Thank you. Dr. Liaka, let's take one question from Jessica. Make it precise and to the point, and that will be the last question. Thank you.
Thank you. This is to Dr. Sinavulia. You've talked of providing information to the changes of the clinical guidelines. And I'm wondering, have you taken a step to share your findings with the national medical stores so that they can also revise their product list in the line of hypertension? Thank you.
Thank you. Dr. Zhang, you can start with your questions.
Thank you very much for the question. It's a very good question. And at the beginning, we hypothesized that anthracycline may increase the patient cardiovascular disease risk by first they can increase the non-HDL level or decrease HDL level, and also they may affect the pattern of LDL subtraction pattern. Yeah. So in our data, we found patient has increased triglyceride, total cholesterol, and also LDL, but we didn't find any significant change after chemotherapy of HDL level. And again, we found increased level of apolipoprotein B, and which is representative of non-HDL cholesterol. So that is actually go back to our hypothesis. Yeah, so it's reject the null hypothesis. And also our changings of LDL subtraction pattern, and we found the 5 patients has transferred from pattern A to pattern B, which also has an implication of a high risk of cardiovascular disease. Yet before the chemotherapy, none of them, they are all pattern A. Yeah, we know a lot of data on other population showing the similar result of increased non-HDL and decreased HDL. Our research is a pilot research, and the sample size is really small, so that's why we didn't find the reduced HDL level. Yes, but for the LDL subtraction, actually, I think it's the first study to investigate on that. Yes.
That explanation. So I'd like to invite Dr. Sinavulia to give a comment on those multiple questions.
Okay, thank you so much. Starting with Dr. Muhoz, the surgical plan for these patients, we've done the congenitals. For the RHD, actually, that's where we started, and we had a good plan. So we haven't seen patients yet. I think the first 2 patients, they are being managed at the UHI, but the long-term plan was to actually boost the anticoagulation. In this program, we acquired point-of-care anticoagulation machines, but because we didn't have patients there, these were donated, and they supported the patients at the UHI who couldn't afford. But once we get them, we have an infrastructure that's built where we'll be able to even manage anticoagulation, surgical care, because once they get the surgery, they should be managed closer to home so that they don't spend a lot of money. I hope I've answered that to an extent. A question about the new drugs. Yes, like I said, the revision of the essential medicines list is actually the key thing to enable the lower centers to be able to get them, because it's a pull system. It's no longer a push system. So the education, the countrywide education, WHO through the DCAD project, They're doing a lot of hypertension training, and they're using these tools to actually tell the health workers that, look here, we have better molecules. And the interesting things, they are cheaper. Amlodipine is very cheap. It was tagged to a higher center, but the costs have come down. So the health workers have to actually pull these. In Kazo and Ruel, I told you there is a program that you're running with Resolve to Save Lives. It's running for 1 year. We are midway. I was really impressed when they went to do a baseline that they found in a health center 3, amlodipine is available 56% of the time. For me, that's evidence that actually, without active doing so much, there are other players. We're not the only players. We changed the guidelines, we advised, but there are other players who are doing the training, and actually it's working. That's why I said, go to your health center 3s, tell them the word, they will pull these drugs to them. The singular approach, hypertension, I mean, it's the elephant in the room, and all the other things. So we need to make noise about it. So I'm one of those people who is going to keep shouting. But the good news, the organization I represent, UNCD, it's Uganda Initiative for Integrated Management of NCDs. We do work in all NCDs, and we front the integrated approach. So if you read about our work, you're going to appreciate that there's a lot of integration that's happening. But this elephant has to be highlighted. Beyond MJAB work, Anxious, thank you for that question. I mean, MRC, my great friend whom you're representing, we've worked together, and they are doing a lot of work. And unique to us, for them, early on, they went to the general population. As we were focusing the HIV space, for them, they were already, and there is actually, in my presentation, I hinted to their work. So it's already beyond. Of course, we also have to move from buying drugs for patients. So some of the programs we are doing, there's one that's ending, I think, next year. One of the mistakes I told my research associates and the people we are working with, that it's not an error, because we had to prove the science. I mean, where in the world have they had control of 76%? We had to to buy the drugs, remove that barrier. But now that we know, that's why we changed the essential medicines list. In one of the projects in Kazo and Luero, strictly no buying drugs. We're working with patient support groups, because just imagine somebody spending 60,000 a month, and then you present this to them where they can spend 10,000. That household, they can treat 6 people, you get. So even as we go out, we are deliberate. Use those resources effectively. And we are discussing beyond even Uganda, what they call the pool system, pooled procurement, because these drugs want to eliminate the middlemen. I hope they're not here. But if you are here, I want to eliminate you, the middlemen. That will make the cost really affordable, because we don't want people to die on us for simple things. Jessica, the NMS was involved. We were deliberate. You know, to do this implementation, you have to be smart. You have to involve everybody who matters. So they were involved, they revised. Even when you read the essential medicines list, their names are listed. So it's not a document for a selected few. It's a Ugandan document, Ugandan experts, Ugandan stakeholders, and researchers here in the room. That's the approach I really implore you to use. Don't stress. Invite those who can cause headache. In Uganda, bakuita kugema. Bageme, by bringing them on the round table, discuss together, you're going to come up with solutions that are cheap, affordable, and sustainable. Should I talk?
Dr. Doreen, answer our questions.
Okay. Thank you so much for those wonderful questions. I'll start. Can I use this one? You can hear me? Okay. I think I will start with the question on sensitivity, because most of the questions that have been asked to me are related. And what I must say is that Adunu program is the first of its kind to implement rheumatic heart disease screening within a public health care system. While rheumatic heart disease screening has been done widely in research settings that are really controlled, we have no program to guide its implementation, like translation into a real-world setting. So ADUNU provides a great opportunity to learn and to guide programs not only in Uganda, but in the region at large and in settings where rheumatic heart disease has been endemic. And so this training program is really setting a foundation that can help us improve and develop a standardized curriculum. About the impact of sensitivity, yes, sensitivity was low for all trained providers. Like when you look at all the providers that were initially certified to start, sensitivity was low. But for that specific population that managed to achieve final certification, they achieved 90% sensitivity. And these providers actually contributed to the largest number of screened participants. Meaning that, and these are the providers that are still continuing to screen. Meaning that even though there were few compared to the total trained, they are making a big impact in unveiling the burden of rheumatic heart disease in the community. And maybe this is just a lesson for us, just like I said in the presentation, that going forward, how can we identify characteristics of providers that are more likely to adopt? Because you know screening is a skill. The more you do, the more you're more likely to identify a patient. So if you do less, of course, you will not achieve the required skill. And so the onus is on us to identify those characteristics of providers that can really adopt this. And if we are recommending to the Ministry of Health, we must go with clear guidelines on how to implement the training. And yeah, I think that answers two of the questions. Yeah, but really the general impact is that, as my colleague will present later on, we have a big burden of disease, of rheumatic heart disease, that is really being unveiled by rheumatic heart disease screening. So about, I wanted to chip in one of Dr. Senabja's question, which was about solutions of already screened patients. The goal of screening is to actually identify patients as early as possible so that we can prevent progression of disease. Because now we are having many patients that require surgery that can't afford, and most of them are dying before they can receive that surgery. And in our screening program, we are identifying patients with mild rheumatic heart disease, which can actually improve with just a simple approach as benzathine penicillin injection that is really affordable. And so if we can save many people from traversing that entire journey to advanced disease, that would be an impactful program. I look at HIV and how it has been integrated in care. Like, you can get HIV services at health center 3, health center 4, and you know, we are identifying patients very early, achieving low viral loads. This can be achieved even with other diseases like rheumatic heart disease, if only we can refine the training program. About integration between ADUNU and PEN Plus, this is actually an ongoing process, and we are writing a concept to see how to integrate these two programs. These two programs bring up two important but related things. ADUNU is concentrating and is focused on rheumatic heart disease screening, identifying people with rheumatic heart disease as early as possible. And so we are going in the communities, in schools, at health centers and screening all people at risk for rheumatic heart disease. And Pen Plus is focused on providing care for those identified.
Dr. Doreen, in
so,
the interest of time.
that integration will help us.
In the interest
like
of time, thank
care.
you very much.
Yeah.
Participants can engage you further.
Yeah.
Ladies and gentlemen, let's give the team a round of applause. And thank you very much. Dr. Riaka.
Thank you so much, Agile Cardiology, for those presentations. Without further ado, I'd like to invite Dr. Muchunguzi and Dr. Tumwebaze Hilda to chair the next session, which will be looking at rheumatic heart disease. We have 3 presentations. You're most welcome, Dr. Hilda. You can invite the presenters.
Research, rheumatic heart disease research presentation. Yes. Go ahead. Sorry, let me remove my stuff. Good afternoon, everyone. I'm by the names of Dr. Hilda Tumwebaze, and I'm a pediatric cardiologist at the Uganda Heart Institute, and I am co-chairing this session with Dr. Muchunguzi. At least since morning we have gender balance. Sorry. The next session is about rheumatic heart disease, research presentations. We've already heard a lot about rheumatic heart disease, even just a few minutes ago. Uganda definitely is at the epitome of RHD research, and Uganda Heart Institute is the driving force of this research. And the only research group that we have at the Uganda Heart Institute, as earlier mentioned by the research agenda, as they did their findings at the Uganda Heart Institute. We've done a lot of studies in the communities, in the schools. We've done clinical studies. We've gone as far as doing the genetics of rheumatic heart disease. So this is really, rheumatic heart disease research is always exciting. So our next presenter is going to be Dr. Mary Teddy Akech. She's a pediatrician and a finalist pediatric cardiology fellow. And the work she's going to present is part of her requirement to completion of her pediatric cardiology fellowship. She's a God-fearing lady, and she's a wonderful mother. Dr. Akech, the floor is yours.
Thank you very much, Dr. Hilda. Good afternoon, everyone. It's good to be here. And apart from everything else that Dr. Hilda said, I'm also very humble. Yeah. 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 So I think we have a bit of a hitch, a technological hitch here. So, yeah. I don't see it yet. So we did a study on implementation of simplified acute traumatic fever diagnostic and management algorithm by frontline healthcare providers. Yeah. Sorry.
So, Dr. Kate, about it's freezing.
Yeah. Sorry about this. In terms of introduction, we know that acute traumatic fever is an autoimmune disease secondary to poorly treated or untreated group streptococcus infection, and if poorly treated can progress to rheumatic heart disease. And like we've seen in several of the presentations, rheumatic heart disease is the most common in our settings. We are an endemic setting for acute rheumatic heart disease. It's the most common acquired heart disease. And when not detected early, patients usually present when they are very sick, can present in heart failure, that's present with a stroke, others have infective endocarditis, and several studies done in our settings have shown that most of the patients who present with rheumatic heart disease in our settings actually present with advanced disease, and 17% of those die actually in 1 year after diagnosis. And like the majority of those who die from rheumatic heart disease die in the first 3 months of diagnosis. So in our settings, there are several studies. We see that the number of patients who have group A streptococcus infection are documented, and those who have rheumatic heart disease are also documented, but there is a gap in that precursor, the acute traumatic fever diagnosis. Yeah. So like many people are not, many patients with acute traumatic fever are not being captured to prevent them from progressing to rheumatic heart disease. Yeah. And yet, from studies that have been done in Uganda, we see that ARF actually still persists within our communities. There was a case-finding study in northern and western Uganda where you see that the incidence was about, we have an incidence of about 25 cases. In northern Uganda, 25 cases per 100,000 person years. And then in western Uganda, about 13 per 1,000. So why is ARF underdiagnosed in our settings? We think one of the factors could be poor health-seeking behavior. There may be overlapping conditions and subtle presentations, but also lack of diagnostic tools. Acute traumatic fever doesn't have one specific diagnostic test for you to say this is ARF. It depends on the Jones criteria, which has evidence of group A streptococcal infection and this joint involvement, cardiac involvement. But we don't have the resources required to make this diagnosis using the Jones criteria. Is not available in most of the lower facility health facility levels of health. Yeah. And then we've done studies. There was a study done by Dr. Ndagire and the team that showed that for a health center, a lower facility health center like a health center for them to be able to diagnose the ability with the available resources they have, like the ability to diagnose RIF was like at 68, 66%. And this ability improved as you go higher in the health sector, in places where they're able to do diagnostic tests, they're able to do assault. You see that the ability to diagnose RIF improved. Yeah. So we think that to improve diagnosis of acute traumatic fever, we have to look at several strategies, and there are a number of strategies which I think are being implemented, but our own is to look at the implementation of simplified diagnostic algorithms. Like this is an algorithm that was, this was an algorithm that was developed by the World Heart Federation and a team of experts at the REACH. And when you look at it, it looks at, we look at the most common presentation of acute traumatic fever, which is joint pains and fever, which a lower health worker facility can, and health worker in a lower facility can be able to from the history, and it has options when a patient presents with fever and joint pains. Do they have an alternative diagnosis? If not, is there a high suspicion for acute traumatic fever? So we are hoping that when we implement this, it can improve the ability of the health worker to diagnose acute traumatic fever and treat and prevent that progression to rheumatic heart disease. So we did a mixed method study, had a quantitative portion and then the qualitative portion where we conducted in-depth interviews with health workers. Before this, we first did a health worker survey and then a training, and after the training we did another survey. And then we gave distributed the algorithm and gave case logs for them to record. And after 6 months we collected. The knowledge survey shows that after the training, the health worker knowledge improved from 48% to 85% after the training. And when we, after the 6 months, we looked at the algorithm used, the health workers used the algorithm 61% of the time. And then the accurate use actually was low. Of the encounters, the 61 patients, the health workers had used the algorithm accurately only about 37% of the time. But we see that of those 37% of the time, when they used the algorithm correctly, they were able actually to capture patients with possible ARF. Yeah. So, and then we conducted interviews, and from the interviews, we found that the knowledge about ARF was initially low, but it improved. But during the training, I think knowledge, wanes with time. So at the end of the study, I think there was a bit of a mix-up in the levels of knowledge. The algorithm was clear for most of the health workers. They were able to understand and flow, because it says from this, do this, and it enabled them to be able to give them the confidence to use to treat acute traumatic fever. And then the major challenges with the algorithm was, one of them was its design. Most of the health workers preferred that it should have arrows, and that shows from this point, go to this point. There are arrows, but there are dots. They prefer thick lines. And then the other challenge was that the dosage of benzathine penicillin was not included. So like it tampered with clinical decision making on the part of the health workers. And then the other one was, the biggest actually, was the resource constraints, limitations in, like, if a patient has fever and joint pains, you want to there are differentials, of course. There are many things that can cause a fever and joint pain. But in the health center force where we are in, most times they were not able to do basic investigations, CBC, CRP, Sometimes even the MRDT kit was not available. Yeah. And then the referral system was also a major challenge. So from this, we see that the training and orientation was good. It improved the knowledge of the health workers, and the tool enhanced their ability to diagnose and treat RF, but there were challenges which I've talked about, the age specifications, the dosage of benzathine, and then knowledge interpretation was actually a major challenge, because during the training, of course, you see the cascade of acute rheumatic fever, superficial group A streptococcus infection, and then those symptoms. So most of the health workers actually included any patient with a sore throat, any patient with a cough, they included in the algorithm. So I think subsequently we should support them to help them understand better. So while simplified algorithms like this can support early detection of acute rheumatic fever at the primary care level, there are still a number of limitations. And then improving the design of the algorithm and incorporating it into treatment guidelines would help. But most importantly, improving referral pathways, and then decentralizing RHD services, I think would have a better impact. Yeah, thank you very much. I want to acknowledge my supervisor, Dr. Eman Dagire, and my mentor, Dr. Judith Namuyonga, Mr. Jaffes, the entire team at Uganda Heart Institute. For your matter.
Thank you, Dr. Akech. As a co-chair, I will now take the opportunity to welcome Mr. Jaffes. We've had to change a bit of the presentations. We'll have to skip 2 of them and have 1 more. So I welcome Mr. Jaffes Pule, who is also a budding research scientist. He's a PhD candidate. He has interest in implementation science. Right now, he will speak to us about the outcomes of the integrated RHD screening and treatment within the ADUNU program. Mr. Jaffes, you're welcome.
Thank you, Dr. Atkunda, for your kind introduction. It's such an honor to be introduced by you. And thanks, everyone. I'm happy to deliver or present this study, which looks at the early outcomes of an integrated program for RHD screening and treatment in northern Uganda, particularly in Kitgum district in Acholi sub-region. And this study is part of my PhD work. I'd like to acknowledge my lead supervisor, Dr. James Kaima, who is not in the room, and Professor Nelson Sewankambo, and others that I work with within the ADUNU program. I have no declarations, but as way of background for this study, in 2018, if you're familiar with rheumatic heart disease literature, the World Health Assembly passed a resolution urging member states to prioritize rheumatic heart disease, and this is in most endemic countries. And Uganda was one of the signatories of this, and we are well represented in Geneva, Switzerland for this. And one of the things that is a challenge, however, is that much of the supporting evidence for rheumatic heart disease control stems from studies that were conducted decades ago, and that was before widespread adoption of rheumatic heart disease screening using echo. At that time, it was mostly auscultation, which studies later found. There's a substantial gap that antibiotic prophylaxis effectively in endemic regions, for example, Uganda. So this study is nested within ADUNU, and I just wanted to very briefly talk about ADUNU, which you've heard from Dr. Nakagai Doreen, and it's a descriptive analysis of our data from the Arduino program, which we launched in 2023, and this data was collected from May 2023 to December of 2024, and we examined the patterns in screening and uptake of clinical follow-up in the program. The schematic there, the diagram, shows you that in Arduino or in Kitgum district, what we are integrating or in the already existing public health system is active case finding, where we are using task shifting. And this is by nurse-led echocardiography. I mentioned earlier that we have handheld equipment that we provide to the trained nurses that Dr. Nakagai mentioned earlier, and they're able to use a few windows or a few views to very quickly screen for rheumatic heart disease. And when they find someone that is suspected to have rheumatic heart disease, they refer this person for confirmation at the district hospital, at Kitgum General, and from there, these people undergo a comprehensive echo for confirmation, and then they're initiated on treatment with the hope that this will improve the outcomes for rheumatic heart disease overall. So what did we find when we looked at this data that was collected over 18 months? So we found that the program was successfully integrated into, rheumatic heart disease screening by nurses and all those that are trained into the existing system in Kitgum. We enjoy a lot of support from the leadership of the health department in Kitgum district, and over 25,000 people were screened by December of 2024, not 2025, and the rate at which we are screening right now is at 0.7% of people. That's about 1% of the total population of the district is being screened per month. And you can imagine what that will turn out over time if we're able to reach people. And I mean, we're curious to see how it goes over the years if after 5 years we're able to reach, say, 50% of the population. If you know the population of Kitgum district from the recent census, you'll see that 25,000 is about 10% over people that live in Kitgum currently. And we constructed a cascade that is two-part. One of them looks at people that were screened. After screening that many people, 25,000, we had about 12,000 that were positive screens, and out of those, around 972 received a confirmatory echo, and out of those, as you can see, 359 were positive confirmatory echoes, and we enrolled into the registry 333 and initiated treatment among 321, 33 of whom were on oral antibiotic prophylaxis for most of the reasons being severe disease or people that react to penicillin. And out of those, the ones that had their first injection of us shot were 292 and 218 had adherence that is 80% and above, which is the acceptable level of adherence to protect someone from recurrent episodes of acute rheumatic fever. However, a challenge emerged in linking individuals with positive screens to confirmatory echo. We also found that the adherence to secondary antibiotic prophylaxis in this program was, relatively higher than those other programs of rheumatic heart disease around the world. And we also found that still those that were not adherent were likely to drop off care within the first 6 months of treatment. So this study demonstrates that high volume screening, reaching close to 1% of the population per month, is feasible within the primary healthcare system when carried out by the trained health providers, and that These findings also reveal key areas of improvement, particularly linking positive screens to confirmation and keeping them engaged in care. I'd like to acknowledge that this study is funded by the National Institutes for Health and the D43 Impact Program at Makerere that funds my PhD. Thank you so much.
Thank you so much. We are going to have a combined Q&A for this presentation and the following one. So at this time, I'd like to invite Matron Anne Okechayot, who is going to moderate the next session, in which we have 4 presentations. Matron Anne, you're most welcome. Matron Anne is the PNO of that institute, but she also has a team that she works with. Her deputy is here, Matron Munduru Jane Francis. You can wave at us. We also have different people here who work with her, such as Matron Leila Aikoru. She's behind there. Matron, wave to us, please. We also want to recognize the assistant administrator of the hospital, deputy. You're most welcome. Good to have you here. Also from the Nursing Council, she's here, the one who had a lot of questions. I can see her and the director now, they're now smiling and laughing together. Yes, so Mrs. Nabukera Agnes is the Assistant Administrator of the Heart Institute. She's most welcome. The other allied staff members of Heart Institute, you're also here. You're most appreciated. I already introduced Mr. Keba, who is head of our lab services. So, Matron, you're most welcome to moderate this session. Thank you.
Good evening, ladies and gentlemen. I know this is time everybody thinking of going home. Let us stand up a bit out of our seats and we stretch a bit. All of you raise your hands high up in the sky and touch the ceiling. You can sit. So I'm happy to stand before you. I'm chairing this session with my co-chair, Mr. Caesar Mbabazi. So there's gender balance as well. So we see that throughout there has been a gender balance throughout the session. So nurses are always the silent heroes. And I'm very proud to stand here before you to know that with nursing, hospitals cannot run. We are always the flowers in the hospital. So we are proud to be before you. And I'll request all the nurses who are here to stand up for recognition. These are the pillars of medicine. Thank you so much. So I'll start by inviting our first presenter, that is Ms. Samali Chitoleko. Samali is a graduate nurse. She has an advanced diploma in leadership and management. She's a professional nurse for 29 years in clinical experience, 23 of which she has spent it at the Uganda Heart Institute. So these are the founders of Uganda Heart Institute. We are proud to have her here. She's a cardiac nurse fellow and very passionate about rheumatic patient care. So she has done so many researches in rheumatic heart disease. Most of the presentations that have been given, Samali is part of it. That's why I've told you nurses are the silent heroes. She's a heroine of Health Award winner of 2017 in Geneva, Switzerland. So Samali, you're most welcome for your presentation.
Thank you, my senior, for the wonderful introduction.
In the interest of time, let's begin. Unfortunately, much as I love RHD, this work is not in RHD. I'm an all-round nurse, not only in RHD, critical care, and elsewhere. So this study cut across all aspects of patients in Uganda Heart Institute. The title of the study was to assess knowledge, attitude, and practice of patients' rights. Okay. I was assessing knowledge, attitude, and practice of patients' rights from a patient's perspective, and that was at Uganda Heart Institute. The background of the study, as you know, patient rights are fundamental to the delivery of ethical and patient-centered health care. But despite efforts to promote these rights in Uganda through instruments like the Patients' Charter, which is 2019, many patients remain unaware or unable to exercise their rights. So this study aimed at assessing the knowledge, attitude, and practice of patients' rights at Uganda Heart Institute, which is a tertiary referral center. The method used was a descriptive cross-sectional study, and the study was conducted among 67 adult patients attending Uganda Heart Institute. This number is quite small regarding the numbers we have at Heart Institute. The reason was, it was in 2020, it was COVID time, the lockdown had just been lifted, we had few patients, but also the institutions of higher learning, like where I was, had just been opened. So the time we had was so small, and our authorities had a mandate to make sure they push us out as quickly as possible. So that's the reason why we had a smaller number, probably not a representative of Uganda Heart Institute, but at least giving us light into what is happening regarding patients' rights. Participants were selected using a convenience sampling method, and data was collected through a researcher-administered questionnaire that included both open-ended and closed-ended questions aligned in the study objectives. So out of the 67 respondents, 57 of them had never heard of patients' rights. This was so surprising. And only 43% reported that they had heard of patients' rights. And among those, among those who had heard about patients' rights, the most common source of information happened to be the media, followed by health workers, and then their peers. And while 89.6% believe they should be respected during care, only 70.8% while 89.6% believe they should be respected during health care, and only 70.8% valued being informed about treatment options. Unfortunately, the actual practice was found to be poor, and only a smaller number of them routinely asked for identity of their attending health worker, and 6.3% reported lodging complaints when dissatisfied with the service. I picked out just a few patient rights. As you remember, there are about 20. In the interest of time, I picked out just a few. So in conclusion, although some patients demonstrated awareness and positive attitude towards their rights, the ability to actively exercise their rights remained very limited, according to the study findings. And to address this gap, health education was recommended to be integrated into routine care, and health workers should receive training in right-based communication, because even if patients know their rights, when the health workers don't know the patient's rights and don't practice them, it may not work out. And also, institutional policies must also reinforce patients' rights through visible charters. By the time I did this study, Heart Institute didn't have anything like charts on patients' rights displayed around. I'm happy right now they are there. Some booklets are around which talk about patients' rights, although they have some weaknesses. I have one myself there, but I can't even read it. The font is so unfriendly, and it's only in English, meaning that our patients who cannot read or cannot understand English cannot make use of that booklet. Thank you so much.
Okay, thank you, Samali, for that wonderful presentation. I'm very sure everyone has understood, including our colleague. I think he left. He was from the Uganda Healthy Consumers something. You remember? Everyone has understood. Thank you so much for that concise and precise. The presentation has been on point. Yeah, Samali is my neighbor as well. So if anything attacks her tonight, I'm the first to hear. If she makes an alarm, I will hear and go and save her. My name is Cesar Mbabazi. I'm also a nurse. All my years that I've worked as a nurse, I've worked with Samali. And I've worked under the mentorship of my boss, Ano Ketayoti. I'm very glad to stand here with you and very happy. So, our next presenter, you've been hearing about Adunu. Adunu. Now, Adunu has a field coordinator, the head of the foot soldiers there in Kitgum. He's our next presenter. He's called Omara Isaac. Omara Isaac is a nurse with a degree and is doing currently a master's in public health. He's also a man of God. Yes, he's an aspiring pastor. So by the time his presentation is done, you'll understand why I'm saying he's a pastor. Thank you.
Thank you so much, Caesar, for that kind introduction. I'm honored to be here, and like he said, I'm an aspiring pastor, still doing low-key pastoral work, but yes, I'll get there. I would like to present to you this abstract about some of the work we have been doing under the Adunu program, and it talks about integrating rheumatic heart disease screening into community outreach events. And this was a pilot study conducted at Orom Health Center 3 in Kitgum district. I'm not alone in this work. As you can see, these are some of the authors of this work. Some of them are my colleagues, others are my supervisors, and they're here. And yes, some are those we collaborate with very closely. These are their affiliations. Yes, in terms of background, rheumatic heart disease, as most of us in this room know it, contributes significantly to high cases of morbidity and mortality, especially in children and young adults. Early detection of rheumatic heart disease can improve outcomes through institution of secondary antibiotic prophylaxis. In Uganda, we have what we call community outreach events, which is part of the Ministry of Health initiative to take services closer to the people. And in these outreach events, there are components, or there are services that lower level facilities like Health Center 3s usually deliver. For example, you have HIV testing and counseling that are done through these outreaches. You have deworming. You also have immunization, especially for children under 5. And then there is also STI and STD control through condom distribution. So we envision that, rheumatic heart disease screening can actually be integrated into these outreach events. So we wanted to reach more people by using outreaches as a vehicle for RID screening. And so in this pilot study, were assessing the feasibility of integrating RID screening in the outreach events. So what exactly did we do? So this pilot was conducted in Rome Health Center 3 in one of the outreach posts. It was a one-day pilot. Prior to that outreach event, mobilization was done using the area LC1 person and the VHT of the area. Then on the day of the event itself, we had a public address system go around the community telling people about the outreach. That not many men were being captured through health center screening, so this approach nearly equalized the number of women and men that were screened. And one of the things that we took away from this was that the public address system that was going around the community attracted men to come for the event. They always say that if you want to get men to get involved in an activity, either you bring music or you bring alcohol. In this case, we couldn't bring the alcohol, but we did take for the music, and we saw a number of them that came to get the screening. In terms of those that turned out to be screened positive, they were 13 in total, and all the 13 underwent a confirmatory evaluation on the same day. And out of those 13, 9 were confirmed with rheumatic heart disease, and out of the 9, 8 had mild disease, and only 1 had moderate or severe rheumatic heart disease. So what are our takeaways from this pilot? Number 1, we discovered that it's actually possible to communities that are at risk. These are my acknowledgements, and thank you so much for listening.
Thank you very much, Mr. O'Mara. And I think this is a very good study. We know now how to catch the men. Bring the music, find the men there. That is something very good. Our next presenter is Ms. Ndagire Hadija. She's a medical physicist. She has a bachelor's in physics, master's in medical physics, and she's doing fellowship in medical physics. Ms. Hadija, you're most welcome. She's the one and only one at Uganda Heart Institute.
Thank you very much, Matron, for that introduction. Yes, I'm Ndagire Hadija. I'm a medical physicist in Uganda Heart Institute. Today I'm presenting on a topic of assessment of eye doses to the staff involved in interventional cardiology procedures at Uganda Heart Institute. That's the order of my presentation, from background, results to conclusion and a recommendation. Intervention radiology is a special area of medicine that utilizes real-time imaging to diagnose and treat many diseases and conditions. For interventional radiology procedures, we have procedures like angioplasty, permanent pacemaker, pancreas, coronary intervention, to mention but a few. For the eye doses, eye doses, when I say eye doses, those ones refer to radiation exposures to the eye of medical staff. Remember, when they are performing these procedures, they are ever inside in the room. It's published by recent studies where they are mentioning that eye cataracts is coming on board and actually is affecting the intervention cardiologist from 38% to 53%. It is on board. And then for the nurses, also it's attacking them, but their level of being attacked by this eye effect is by 21% to 45%. Actually, the International Commission on Radiation Protection stretched it out recently with a study that it's removing the annual dose rate for the eyes from 150 millisieverts to 20 millisieverts, reducing it to 75, meaning that this is to bring the, if you don't really put knowledge in your head or apply radiation protection, it can hit you at any time. For those who don't know about the setup of intervention radiology procedures, this is a fluoroscopy imaging system. This is how it is scheduled. It is located, as in it has X-ray tube. Patient lies on the table. We place a foot pedal, and then radiation is radiated out. Then we are able to see the images on the monitors. Radiation is not small. We don't have small radiation or big radiation. That's why I say I'm doing this. What is small to Hadija can be very big to other. Therefore, here in intervention radiology, we have the primary beam, which is the X-rays that are going through the patient, then the scatter radiation, which I'm assessing for the eye effect, then the leakage radiation too. In intervention radiology, we work with the energies, low energies, 10 kilo electron volts to 125 electron volts. The general objective was assessing the eye dose to the staff involved in intervention cardiology procedures. The specific objectives were to determine the radiation dose for the selected intervention radiology procedures carried out in cath lab, and a second one to evaluate the radiation equivalent dose to the length of the eyes involved in the selected procedures. Its significance, it's for patient safety and minimizing radiation risk during intervention radiology. The scope of the study, it was, we used the bioplane cardiac catheterization equipment, both a group of adult and pediatric that went through these intervention radiology procedures. Data was collected for 3 years between those intervals, and then equivalent doses for the eyes, to the length of the eyes for the procedures being performed was collected. This is our suit. I call it a suit. Other people call it catheterization laboratory. Therefore here, this is, I don't have a cursor, but ideally in the cath lab, it's a team. People work inside in the cath lab. It's a cardiologists, interventions, cath nurses, anesthesiologists, cath technologists, and they wear this. This is called a dosimeter. If I can trust, people can move with it, but it's a property of Heart Institute. If I lose it, it is 800,000 to be paid. That's a dosimeter which they put on it. It has a thermoluminescent dosimeters inside. Therefore, it's worn after 3 months. They are taken for reading and excited. Then we are able to pick the results. This is more of the details of the equipment. Therefore, the data collected, it's from Atomic Energy Council that reads the dosimeter, those TLDs. Then the data we collect, when it is brought back, I collect the data, we put it in Atomic Energy Intervention Radio Collection Tool, and then it is analyzed. For the angiography data display, this is how it is displayed at cath lab. Please, you are welcome to come and see the physical display at the institute. And then mainly in here, we are able to pick out these radiation dose parameters to include dose area product, it's dose times area, and this dosimeter, it's already in the equipment. We are able to get the entrance skin dose, reference air comer, and then time of exposure. As I've already told you, for the equivalent dose, it is a dose we pick from the sheets, and then it's evaluating the dose to the skin at a depth of 0.07 and extremities. Therefore, with that, we can use Python to analyze, or Excel, if you don't have Python, to analyze the mean, the median, maximum value, and upper. For the distribution of intervention procedures, there were 120 angiography procedures. This is the distribution because of time. This is the distribution of the procedures we followed. And then, as I told you, determine radiation dose parameters. The key ones are the dose area product, fluoroscopy time, and entrance dose. We were analyzed using box plots, and then we were able to know the median, the mean, the interquartile, respectively. For the equivalent dose to the eye, as I've said, that dosimeter, we are able, after exciting and then picking the values, using Python, we're able to get the maximum doses, and for ours, the minimum is 0.07 millisieverts. These are units of physics. I won't go down to explain. Those who need, you can visit me. And then the maximum, the minimum, it was 0.07, and the maximum is 0.65. I think we are below the 20 millisieverts. Remember what I said, is 20 millisieverts per year. And in Heart Institute, for us, our minimum is 0.07, and the maximum is 0.65. In other words, the medical physicist is doing a good work at Heart Institute. In conclusion, yes, the doses, they are ranging from 0.07 to 0.06 for the eye, but I'm just generalizing. This is an ongoing procedure. As I said, we are having a team of people in cath lab. We are going on with the research to really categorize what about it. Remember, intervention cardiologists, they are the ones who are next to the X-ray tube, as I explained. Then we are having runner nurses and scrub nurses. We are having anesthesiologists. We are very, very, very near to the X-ray tube. We are ongoing with a study to break it down. But at the moment, this is the value. Please, we are below 20 millisieverts per year. You are welcome in our cath lab. We are not exposing people. We are working within the limit. The recommendation is, however much we are below 20 millisieverts per year, the complexity of the procedures is increasing. We've been doing less complicated, but we are going to complicated issues. Therefore, we are likely to have this effect. Therefore, as time goes on, we are recommending always to put on protective eye specs. Many people, they say, I don't see well when I'm putting them on. Please know, this is going to shoot us. Remember, it decreased from 150 millisieverts to now 20 millisieverts. Therefore, protective eye specs have to be put on. And again, we are soon going to have, on top of your specs, I'll put on an additional dosimeter, a TLD on top of it to really record actually what is going to the eye, respectively. And then the active dosimeter is over in the room to really measure. These are my references. Thank you very much for listening.
Thank you, Adija, for that special work. I hope your dosimeter is still available. Guys, where is the dosimeter? 800,000. So our second last presenter, guys, don't go. We have 2 more presentations. This one and the last one is very short. I have to emphasize very short. But this presentation is by Dr. Yakub Hashin, who is a medical doctor. And guys, this is interesting. He's a certified health and wellness coach. And he's a digital health expert. And he heads a social enterprise called Vigilant Living. I'm still adding you. He practices both physically and via telemedicine, so you can consult him in any way about your wellness. And he's going to tell us where he practices from physically, right? And he practices from a place called Center for Health Aging. He will tell us where it is, and he will tell us the rest of the things about him. Dr. Yasin, you're most welcome.
Yes, last but not least, thank you for having me. So I was supposed to present with my colleague, Sandy Ellison Ondo, who is a staff at UHI, a nurse, though unfortunately could not come. So because we work together, I was able to come and present. So I'm talking about technology, IT, AI. I'm happy to see it as a theme. So this is the concept of wearables. I don't know whether you have ever come across any wearable. Anyone who has smartwatch, smart ring? I think many ladies mainly have more than men, possibly. Okay, thank you. So, but even our phones are smart these days. Our phones can collect our data. So everything can be a smart thing. A smart shirt, smart shoes, smart belt, everything. Even a smart door, a smart house. I will leave it at that. So this is a sort of a presentation on the impact of it. Dr. Aliku, one of the best presenters I've seen today, someone asked him about the aspect of self-care. And it's important for us to appreciate the value of self-care. Anyone who knows there's an office for self-care in the Ministry of Health? Anyone who knows the self-care day or the self-care month? So they are all there. So there's an office. The self-care day is July 24th. So self-care is supposed to be 24/7. And the month starts from 24th June till 24th July. Last year, the national celebration was in Kayunga district. This time it's going to be in the eastern region. So it's important. So I wanted to define a bit about self-care. Of course, this is the important data. We know there's a high rate of CVD conditions. Self-care, the official definition, is the ability to promote health, prevent disease, maintain health, and cope with illnesses and disabilities with or without healthcare worker. And that's the future we want to take healthcare. I think we have seen a lot of bad conditions and how our good doctors are treating us, but we rather reduce this secondary and even tertiary care by emphasizing our primary care, health promotion, and self-care. And that's the role, I'll say, of the nurses. Thankfully, I think that is the role of the nurses because, number one, they are more holistic, the nursing practice, but also it is more empathetic. And that's, I think, a fact which is proven. And that's what requires to change a lifestyle. We always meet in patients, you tell the patient, go and change your diet, but do they do it? Often they don't do it. They don't exercise. Because lifestyle change is not straightforward. You just don't tell them. It requires a holistic angle. And unfortunately, in the current practice, we have overwhelming traditional medical practitioners. I think the latest research shows 60 to 80% of Ugandans are using herbal medicine. So it shows you we have left a big gap. Okay, all right, now I'm going to finish up quickly. So it shows you how we need to be proactively dealing with our clients. Yes, we're experts in the sciences and the practice, but we still have to have the human element and the human touch. So this study, the aim was to evaluate the effectiveness in identifying and reducing the risks for cardiovascular disease and improving outcomes. These are hypertension. I think we have seen the figures today. Diabetes is also there, very amazing. I think Dr. Luko was also saying something which is necessarily not correct because 80% of Ugandans don't know that they have diabetes. So it shows you how it's scary it is. I don't know how many of us know that we may have it because the rates are, I think someone mentioned 10%. So 1 out of 10 has diabetes. Risk factors, obesity. This was a research which was published in a paper late last year, half of women in Kampala. So it's an interesting study, but I want to put a disclaimer there to say the reasons why though men might not have obesity or might not look obese, but actually get more NCDs. Number one, the fat distribution is different in men. Mainly men, it comes to the stomach and the visceral, which is more dangerous. Number two is what we call the size of the fat cells. So for women, they have more fat cells. For men, the size of the fat cells are bigger which is why we lead for them to have metabolic syndrome and chronic inflammation. So just because men are not stated here, does not mean they are safe. Yes. And maybe alcohol, which is also another important factor. And Uganda is top 10. Uganda is the only African country which is in top 10 alcohol drinking countries. So you can also see why we have a lot of NCDs. So the methodology of this research was about how the systemic review from 2015 to 2024, which was mainly on the study of wearables and the apps, the mobile apps, on the impact on physical activity, diet adherence, glucose monitoring, and cardiovascular health. And that's how the data was collected. So the key results showed that in 45 studies, more than 30,000 participants, there was a 25% increase in daily physical activity, 15% reduction in BMI, improved glucose control in diabetics, and as well as heart rate and blood pressure monitoring led to early detection and early intervention. So that's the beauty of these devices. There are people who actually got saved from atrial fibrillation just because of their Apple Watch was able to detect. So, and it shows you how it's important. The challenges which a lot of these devices face currently, number one, they're expensive, a lot of them, which is not even stated here, but also there's a lot of dropout because people don't want to be monitored. I would like to mention an interesting story. There was a lady who ended up breaking up with her boyfriend. Simply why? Because her smartwatch was connected with his, and he detected at night around 4 a.m. that he was having a heart attack. So it's like, what happened? He came in the morning, he was already drunk, and she was able to know perhaps he was not having a heart attack. So data privacy is also a big issue with these aspects, the challenges and the concerns. So lastly, of course, the access is a challenge. So something interesting is the aspect of self-care. There's what you call the WHO self-care framework for staff, for healthcare workers. Actually, ourselves, because we have to start with ourselves. Physician, heal thyself. And unfortunately, the rates are low. Actually, we did a small survey in a good hospital, and it showed a lot of healthcare workers. Now, how do you supposed to preach to a client when you yourself are not proactive on your health? So we need to up it up, and perhaps we can do research at UHI and see whether the staff are maybe actively promoting their own self-care or not. So lastly, recommendations, yes, we need to improve the accessibility, data security, as well as user engagement. And the policy to support this NCD. The NCD is real, NCD is huge, and I think we have seen not just CVDs, but also the DM, the cancers, all of them are infertility, mental health disorders, arthritis, etc. All of them are related. And lastly, AI. The power of AI is that it can analyze data. Now, by the time you're consuming data from a smartwatch, that's what we call big data. There's a million terabytes, and a human being might find it hard to be able to analyze it. And that's the value of AI. To not just take our jobs necessarily, but it will help us to become better clinicians. In fact, there's a saying which goes, clinicians which use AI will replace clinicians which don't use AI and digital health. Finally, the future is already here. It is just not evenly distributed. Thank you.
Okay, this is the last presentation. Thank you, Dr. Yakub. I don't know what to say. Hey. So this is our last presenter. She has been here. I will not say much. Dr. Judith Namuyonga, but all I can say is that she's a good doctor. For us, we can testify, those who work with her. She's a very good and compassionate doctor. You're welcome, Dr. Judith, for the last presentation.
Thank you so much, Caesar. It has further implications why I have to present it, just to show the work that has been done at the 2 Pen Plus sites. Dr. Senabuli already talked about the WHO Pen, and so this work just summarizes the echocardiographic cardiac diseases identified and how they were linked to surgery at the two Pen Plus centers. And he defined what the Pen Plus meant. I don't have to go through that. The purpose is to really enhance access to non-communicable disease care at a district level. While UHI is the super specialized unit, WHO and Ministry of Health purpose that also this work gets to the grassroots. So we'll have the 5 centers, but we're also looking at district centers. And because of this work, they have rolled out also, there's willingness to roll out to 20 other general hospitals. We are a team, and Dr. Isaac is at the back. So we did a retrospective review of the echocardiography data that came from Atutur Hospital and Nakaseke hospitals. And between 2023 and 2025, we had to train mid and low healthcare workers. This is including sonographers, nurses, clinic officers, and physicians in Tutur, and then Nakaseke has a pediatrician on top of the teams. We took them through segment analysis. There's a protocol that we have designed. Because Uganda is part of this work, we are leading actually in the cardiovascular aspect of diagnosis and leading to surgical care. And we developed a protocol for echocardiography. So we just didn't want to look at, for instance, what the RHD team has been focusing on, look at the mitral valve and aortic valve, and then diagnose. We chose to be a patient care centered team. So we actually do a segment analysis from subcostal to thoracic, short axis, parasternal, long axis, up to the arch, because we know once a patient encounters a clinical worker, they have one chance to have their heart scanned, not just to look for RHD. And of course, as Isaac said, we went, the funder knew that there was a lot of RHD in Uganda. We were really, really surprised, because with this protocol, you can't miss mitral regurgitation or aortic regurg. So we also looked at the data that is collected for the patient outcomes, clinical presentation, how many were referred for surgery, what is the morbidity and mortality, and this has been cleared. The project was cleared by the Mulago REC. So we looked at 273 echocardiograms. Atutur has 143 echoes that were done in 2 years, and it was the first site that was enrolled and trained, and then Nakaseke came on later. But Nakaseke has almost gotten to the number that Atutur did in 2 years. The reason is that one of our key people that learned echocardiography very well, who is a physician actually, became the medical superintendent and got very busy. And so when she got busy, we had to also retrain others. And so we picked out what was the most presentation. The patients at Nakaseke were between 14 days of age to 85-year-olds. Atutur has older patients, months to 100-year-old patients. And he already told us how many had DCMP and congenital heart disease. So they were referred to the Uganda Heart Institute. This is a Atutur hospital. So every 3 months we do a review, and in one of the visits we had 16 patients that were awaiting surgery, and of the 143, that's about 11%. 12 of them were children under 18 years, and congenital heart disease was the most common, again at 68.7%. RHD were only 25%. Atutur has a very huge clinic with sickle cell anemia. 2 of the RHD patients actually had sickle cell disease. We have also a 7-year-old who is a truncus diagnosis, and that one is really inoperable by now. 7 surgeries happened at the Uganda Heart Institute from Atutur. That's a hand of us really training some of the nurses, and this is the physician that is now the MS. So we really have to hold hands and show them how to do images, and nurses are giving us very good echoes. The nurse in Nakaseke was able to diagnose tetralogy of Fallot by echo. So I think that's a summary. Among the morbidity was a child with tetralogy of Fallot who got a brain abscess. I'm sure the team at UHI knows that child. 9-year-old with long stay, the abscess was drained, but unfortunately we can't push that child for surgery because of already the comorbidities. And our center is still growing, so when we are selecting patients for surgery, we are very careful on who we send to the surgeons. There were some deaths. In March, we did a visit, and in that visit, we listed 4 patients that were very urgent for surgery. And from March to June, we've lost 2 patients on that list who were waiting. So in 3 months, we are losing 2. One of them was operated, no, he's not yet actually. So one who died was a double-chambered RV and had obstruction in 2 sides, the right ventricle and the left ventricle. He was a 12-year-old who had been with us at UHI from 2017. So we had gotten actually an opportunity to operate him in the camp that ended, but he died that same week. And then the tetralogy of Fallot with recurrent TET spells. The other deaths that occurred in the space of waiting of the 2 years study was a Down syndrome who had an AVSD and came with cardiac tamponade. And we let the health worker look at the images, so they would send, before we got the online system, we would do WhatsApp videos and were able to diagnose and give a second opinion. One patient died of anaphylaxis to BPG, and another had severe heart failure. So for Nakaseke, we've only had 3 children that needed urgent surgical referral. And 2 of them had PD ligation, 2, and then 1 VSD closure, who Isaac spoke about, who had a diagnostic cath because he was 12 years old. We must say that because of looking for funding, Pen Plus didn't start with a purpose of knowing that we would find congenital heart disease and link them for surgery. The protocol actually had rheumatic heart disease and other NCDs. And then we kept finding congenital heart disease. And because of this, the funder has been able to release just some little money that is going to help out some other children. It's not a lot. It can operate about 2 or 3 children. But we've been hunting for money and hunting for positions for surgery. So this particular child from Nakaseke, we got funding from the Rotary Club, the Camping Fellowship. They'll be having a dinner tomorrow. Director, I think you were invited to celebrate the work. So the Camping Fellowship looks for money, and they mainly have supported PDA ligations. This particular child was funded by them. The father cried when he was in HDU. He sneaked in these pineapples into the HDU to make sure he gets us on the ward round to give us pineapples. When the Rotary Camping Fellowship leader had brought the check to pay the Uganda Heart Institute for the surgery of Noella, the little girl, and this is months after they still came to Masaka, still looking for money for other PDA ligations. So tomorrow we'll be hearing what they have to tell us. So in conclusion, echocardiography within the Pen Plus programs at Atutura and Nakaseke General Hospitals demonstrate a significant role of skills transfer and also bridge a gap in the resource-limited settings where we don't have many cardiologists. It's possible to manage patients from those centers. Congenital heart diseases in children and acquired heart diseases were the most common that we found. He said 12.5% in the children had congenital heart disease, and then 12.5% were cardiomyopathy. Thank you very much.
Thank you so much, Dr. Judith. We thank you who are still here in this house for the remaining part of the conference. Quite lovely presentations, especially from Dr. Hyacinth. That's quite interesting. So I think we need to adopt those AI and use of technology to enhance our health more often. Can save our lives. I noticed that it's now coming to, it's now 7:06 p.m. and we need to close urgently. We have a program left. Chairperson for the research committee, Dr. Judith. You have presentations for awards for the best presenters of today. So at this point in time, I'm going to invite you to come over and please announce the best presenters. After that, we will have the closing remarks from the organizing committee and the director of that institute before we depart at leisure.
Thank you so very much. I first of all want to thank you all for sparing your time to come for the Dissemination Day. So we had 3 local adjudicators for the abstract sessions, and now I'm happy to declare who they are. 2 of them have gone, but they had already read through, and what we did was to send the abstracts by email and some by WhatsApp for them to review 2 to 3 days ago, and then come when they already know what is good. So Dr. Joan Nangendo is around. She represented Professor Kalyango Joanita from the epidemiologic department. And why we chose them is we wanted people with a wide range of skill in research to build us from our baby steps. Professor Musime was the second person who left, and then Professor David Mayer, who also left. The last 2 are head of departments. I just got to learn. When we chose the names, I could not even tell that. I knew that Professor Musime was head of department pediatrics, and then Professor Mayer is head of internal medicine, and then Joanita represents clinical epidemiology, which is very good, and this is what we need. So other than those, we also shared these abstracts to one of the international friends who is a researcher that is at Amrita Health Sciences, and independently he selected 10 best abstracts. I will start with those 10 best abstracts and then have also our local reviewers. And so among the 10 best abstracts in that order, we had delivering rheumatic heart disease diagnosis at scale performance and performance of an integrated public health screening in Uganda. I think that is Japheth. Is that you? Let me just quickly look. It must be him. Delivering. I don't see it. Delivering RHD disease diagnosis at scale. Performance of an integrated public health screening program in Uganda. Then Jocelyn's paper on cost of school screening for rheumatic heart disease was number 2. And then echocardiography identified cardiac disease and linkage to surgery, this last presentation. And then health-related quality of life of Ugandan children, that is Dr. Ahmed. Rheumatic heart disease care cascade, early outcomes of a control program integrating screening and treatment into primary health care in Kitgum in northern Uganda. Is it, it's you, Japheth? Yes. And then the first one was whose? Oh, yes, you've done well. This is the international reviewers, and congratulations. And then the other is delayed echocardiographic diagnosis of congenital heart disease and its associated factors among children attending the UHI. I think that's Owomugisha, abstract number 6. Then primary surgical repair of tetralogy of Fallot at the UHI, a 10-year review, that is, I think, Kayinza. Then RV dysfunction by echocardiography. Please clap for me. Number 8. Then the role of wearable and fitness apps in prevention of early detection of cardiovascular disease. Where is she? Hey, clap for that lady. Ndagire. And the last one is the long-term outcomes of patients with dextrocardia after balloon atrioseptostomy. So the local adjudicators have mentioned this, that one, actually from all of them, even Professor Kalyango, they say our work is very good. Some of the research is much more skewed to rheumatic heart disease because there's been a research program going on for several years. And they've built a lot of experience. And one of them said that our statistical methods, some of them for especially the upcoming research, are still at the baby stages. We are doing quick direct data analysis and not into the detailed statistical analysis. And let's take that in good faith. Of course, another comment were case reports. They said, should we really value case reports as research papers? But because we are growing our local research, we accepted case reports. So those were the main comments from the local reviewers. And now I want to read the overall results from the local reviewers, and that's what we will go with. Boob, Build Uganda by Uganda. The top 3 overall abstracts today, 17th of June. I'll share this email. The good thing they are on email, so there is evidence. Judith can't doctor anything. Top 3, number 1 is cost of school screening for rheumatic heart disease and the cost of comparison of alternate strategies for confirmation of echocardiography in Uganda. I think that's Dr. Jocelyn Revembera. The second best abstract, and by the way, these are top 3, but in different stratification. So the second is the long-term outcomes of patients with dextrocardia of dextrotransposition of great arteries after balloon atrioseptostomy at the Uganda Heart Institute. That's Dr. Aliku Twalib. I'm going to invite whoever we are reading, and Patrick, you're going to bring us that thing that we are giving. Delayed echocardiography after congenital heart disease, diagnosis of congenital heart disease and associated factors among children is the third best abstract. Congratulations, Dr. Womugisha. Please come to the front, the best 3 abstracts. I'm reading also in the other categories. So we have 1, 2, 3 in the other top categories. Then we have other categories. So those were in RHD and PED. Cardiac surgery, left subclavian cannulation for antegrade systemic perfusion in complex Stanford aortic dissection repair. This is Kenneth Ahabwe. All representatives can come and pick and have a handshake. Dr. Omageno kindly, and the Deputy ED acting, kindly come and give handshakes to these people. Whoever I have read, kindly come to the front. And adult cardiology, we have hypertension landscape in Uganda, evidence, guidelines, and implementation by Dr. Isaac Sinabulia. And then the last category is assessment of eye doses to staff involved in interventional cardiology procedures at the Uganda Heart Institute. Please come to the front. Let's appreciate them. So as they come, we really, really appreciate the teams that took time to do research. This is just a simple, can I have a portable microphone? Thank you. Thank you so much. So this is just a simple measure, Dr. Magino, to encourage local research, research in all fields, RHD, nursing, peds, internal medicine, adult cardiology. It's one way we want to encourage people. So for each of them, they are having their envelope, and this handshake has a khaki envelope for each of the best categories. It may not be so big, it's just out there to motivate you. And on top of that, we are going to get them certificates that recognize that they came out as the best abstracts in the different categories. And then also we will give certificates for whoever was able to present and participate in this. Hang it in your department. Let it encourage you. And let us have research come through from every area. RHD, you've done very well. We want nursing. We want all fields to give us international standard research. So pass on our message. Where is Dr. Muchunguze? Oh, well, you'll send our message to the RCCU group. I see. Thank you so much. So we will give ED. So maybe we start with the ladies. Miss Ndagire, Hanifa, please receive a handshake with a khaki envelope. Good for you. Congratulations. Congratulations. Please keep working. Dr. Owomugisha Gloria, her envelope. Congratulations. Congratulations. Then the youngest. Japheth Pule. Congratulations. Congratulations. And then we have, the last one was Dr. Revembera, and then Isaac. Isaac is here first. For both. Okay. He will deliver. So he receives for both. Oh. It's Congratulations, Isaac. Congratulations. That was very good work. And so I think our purpose is really to close, and I hand over to you.
So, good evening. Good evening. Is everything okay? Good evening. Okay. Please look left and right and congratulate each other. Left and what? And right. You know, members, this event is very, very monumental. And as we agreed, it should be every what? Every year. The other thing is the organizers. The CMU we usually have grade, is it points? You should be able to sign off people. How many points? Pardon? Yes, so let this one go on to people's what? CPD what? Yes. Next, everybody who has attended should get an attendance certificate. Yes. Yes. Now, a special thank you to the organizers. Please the research committee, this is a job well done. On behalf of the board, first of all, management, then the board, then the ministry, and by extension, the government, this is work to be proud of. This work to be what? Proud of. And the institute is now, if you look at the mandate, research and innovation, I think is number what, Lydia, you have it says that D and what, but the point is, we have that one. If you look at it, we are doing the care, there is evidence. We are doing the teaching and training, there is what? Evidence. We are doing the research and innovation, this is what? The evidence. We were supposed to be doing the training, the issue with the nursing council, we shall sort it out. Now there is a better understanding. And we hope we sort it out. It is for the good of the nursing profession and in this country to catch up with the rest of the of the world. Now, the last issue we were not doing very well was the issue of regulation, because one of the mandates that the Act puts on us is to take on a responsibility of ensuring that cardiac services by any public institution measure to a certain to international levels. And for that one, we needed regulations. And we are glad to say that in about 3 weeks ago, that process was ended. The minister signed the regulations. Now, one of the next meetings is to popularize. Now, a special mention about taking services to the community. That is a very significant issue of following the patients where they are. If we sit at the center, only 30% of the patients get this way, or to the big hospitals. 60% is in the community. For me, if I think I have to create my own envelope. It is to give the community is the one who devised ways of attracting men for for screening. If there is extra, my pocket is dry, but there is an excess envelope. Yes, please, to me. Omara, please. Yes. No, it is Yusuf. No, it is Omara. Who even they went to the for attracting men who are very poor medical seekers. Catching them for screening is very difficult. And they had to devise ways to go outside the box to see how to attract the men. That is very innovative. The music, that is very, very, very innovative. And you'll get shocked in the international fora, that paper, that innovation may be picked on. Thank you very much. Now, having got this far, we thank everybody for working so hard. We thank everybody for being here. We thank you for persisting. We thank management for availing the funds for this exercise. But for the fund, for the administration, and for me as what accounting officer, the last time we were in the park, this question came up. You have very nice results, very nice publications, but the stakeholders are not aware of them. So we call upon the press, please. I've seen some things already coming, but for them, they picked a few things. Let the community, let the public, just get this information flashed. And for Grace and your team, please flash this. Let the rest of the platforms receive this information. Now, having gone to this point, I would really again thank you. And also there was the issue of the universities and our teams who came from upper country. I was really humbled they have been here. I think without much ado, it is to expect those certificates. Next is we need the policy papers so we can combine all these things and come sieve out what can go, what are we demanding from government. You get it? And the question they will ask, and that is what we want to answer, is the policy papers. What do we want changed? What do we want done? What and how do we want it done? This is the evidence. There is disease in the community. And you are saying we should, but how? So government doesn't, they don't think much. For them, they want a blueprint, and a summary, and then our prayers. The government I know, and the minister I know, will answer them. But if we don't ask, they will instead crucify us. So, the team, please go forward and get the policy briefs. We should be able to present them to the ministry. With that, I see my friend from Kabale. Really, very good, very good, very good, very good. I think at this level, I would use the powers that has been entrusted upon me to declare this meeting closed.
Thank you so much, Oja Director. We thank everyone, the committee, for the research for organizing this momentous function. So we have a cup of tea outside. As we depart to go home, let's just go outside in the gardens and relax over a cup of tea. God bless you and safe journey back home.